Well, good morning. My name is Joe Cressy, and I'm the chair of the Board of Health. Our board secretary has confirmed that we have quorum, so I'll call meeting 33 of the Board of Health to order. Welcome, everybody. Our deep regrets that we are starting late here. We've had a number of tech challenges this morning, and I'd ask our team from the clerk's department if you can continue to work to try to connect trustees Lopretti and Donaldson, as well as Director Mulligan, who I understand are all trying to get in. So I'd just ask if you continue to do that to try to connect them. I know we have Trustee Donaldson by phone, and so we will manage until hopefully we can get her connected by video. To everybody else, I know if you're tuning in, I'm sure like us, you wish you were tobogganing. It is one of those remarkable days, but we're glad to be here because, of course, our work carries on. Today's meeting is being held with directors and city staff participating by video conference. The public can participate electronically, of course, and watch the meeting streaming live on YouTube at youtube.com/Toronto City Council Live. I will ask for everyone's patience with any delays and technical issues, and note again that we now have Trustee Donaldson and Director Mulligan by phone. Though, again, if we can continue to try to connect them, I'd be most grateful. We do have 12 registered speakers. The clerk's office has connected them by phone through audio. And we will begin now. I will ask Director Wong to provide the land acknowledgement to begin today's meeting. Director Peter Wong.
Good morning, everyone. So as we meet today on this virtual platform, the good mind tells us that we would like to begin by acknowledging Indigenous peoples of all the lands that we call home. The land acknowledgement is an expression of gratitude and respect for the land, and one that has been practiced long before European settlers arrived on Turtle Island. Today, we honor the Indigenous groups who asked Canada's Human Rights Tribunal to consider whether the government had discriminatory practices in removal of First Nations children from their families, and also discriminatory practices within the welfare system. So as Canada reaches a settlement with Indigenous peoples, we must recognize that no amount of settlement can reconnect First Nations children and youth with their cultures, nor reverse the suffering experienced by First Nations children, youth, their families, and their communities. So today, as settlers in Toronto, we would like to acknowledge that the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and now is home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 and the Mississaugas of the Credit. Megach. Thank you, Chair Cressy.
Miigwech, Director Wong, and thank you. I'm now going to see if there are any declarations of interest under the Municipal Conflict of Interest Act. If you have an interest, please raise your hand for those on video, or for Trustee Donaldson and Director Mulligan, if you could unmute your mic to indicate the item and nature of the interest. Are there any declarations of interest? Okay, seeing none. We do need a motion to confirm the minutes from our last board meeting on December the 6th. That motion is moved by Councillor Ainsley. All those in favor? Seeing hands. Opposed, if any on the phone are opposed. Trustee Donaldson and Director Mulligan, indicate now. Okay, seeing none, that carries. There are 3 items on the agenda. We don't need to do an agenda run through because we have to address each item. Just for as a matter as voting, because we have 2 members participating by phone as we go through this, I will be seeking to confirm with Trustee Donaldson and Director Mulligan on voting items by phone. For the first item, which is election of chair for 2022 Board of Health, I'm going to cede the chair now to the recording secretary to conduct this item, as I am stepping aside for this one. To our recording secretary.
Directors, are there any nominations for Chair of the Board of Health Directors may nominate candidates, including themselves, and nominations do not require seconding.
This is Stephanie Donaldson. I'd like to nominate Joe Cressy for chair.
So Director Donaldson has nominated Director Cressy. I'm calling for nominations a second time. Are there any further nominations for chair? I'm calling for nominations a third and final time. Are there any further nominations for chair? Hearing no further nominations, I declare that the nominations are now closed. As Director Cressy is the only nominee, I declare him the chair of the Board of Health for a term of office starting January 17th, 2022 and ending November 14th, 2022, and until a successor is appointed. I will now ask Director Cressy to assume the chair in order to conduct the election for vice chair and to preside over the rest of the meeting. Thank you.
Well, thank you kindly. Thank you to members of the board and Trustee Donaldson. Tobogganing, we'll wait till next year. So back in the chair. The next item, election of vice chair for 2022 Board of Health. Directors, are there any nominations for vice chair? I see Councillor Wong-Tam has her hand up. Councillor Wong-Tam?
Yes, thank you. It's been an honor to serve as the vice chair, but I'd like to hand the realm over to Trustee Donaldson. I'd like to nominate her for the position of vice chair.
Thank you for that, Councillor. Councillor Wong-Tam has nominated Trustee Donaldson. Let me call for, are there any nominations for the position of vice chair? I'll call for a second time. And for a third and final time, are there any other nominations for vice chair? Hearing no further nominations, I declare the nominations are closed. As Trustee Donaldson is the only nominee, I declare her the vice chair of the Board of Health for a term of office starting January the 17th, 2022 and ending November 14th, 2022 and until a successor is appointed. Trustee Donaldson, congratulations. Again, tobogganing awaits an additional year. Okay, the next item, which is on our agenda, and it is the item on our agenda, is HL 33.3, Response to COVID-19 January 2022 Update. Members, I would just note that since our last meeting, Omicron has emerged and taken hold. The rollout for vaccines for 5 to 11-year-olds, which began a mere week before our last meeting, has continued at a pace. Third dose eligibility opened up and began. And of course, we are now in the midst of the Omicron wave. It has been a busy period, to say the least. We will have a series of presentations before we hear from our deputants. We have our Medical Officer of Health, Dr. Davila, who will provide an update on the public health response. Chief Matthew Pegg, who is the Incident Commander for the City of Toronto, will provide an update on service continuity. And Deputy City Manager of Community and Social Services, Paul Johnson, will provide an update on the community-based response, in particular as it pertains to our TO supports work with disproportionately affected communities. We'll then open it up. We do have 12 registered speakers on this item before we bring it back into committee. So Dr. Davila, the floor is yours, and I'm glad you could join us today because many of us struggled to get here, but you were here. So over to you, Dr. Davila.
Thank you, Mr. Chair, and good morning all. And I realize it is the 17th of January, but this is the first time I have seen many of you since the new year. So I think it's still okay at this point to say Happy New Year, and it is nice to see so many of you on the screen today. As Councillor Cressy, or the chair, has pointed out, we are going to be bringing you an update presentation in respect of our response to COVID-19. And I will thank my colleagues at Clerks for driving the slides for this morning's presentation. This morning's presentation does include a number of different elements from the public health perspective. The chair has pointed out that there are some other elements of the presentation that go beyond public health, but from the public health component, we will be providing a status of the, an update on the status of the COVID-19 epidemic here in the city. an update on the vaccination efforts, as the chair has pointed out, including vaccine of 5 to 11-year-olds and efforts that we are undertaking to ensure equitable access to vaccine. And finally, updates on recent policy developments on a number of different issues. So let's just launch right into the presentation in earnest. We'll go to the next slide. Which indicates that the next component of this presentation is on the status of the COVID-19 epidemic in Toronto. Going to the next slide, we have not actually had the opportunity to gather around this meeting since early December the 6th. And as the chair rightfully pointed out, there have been many, many developments in the intervening few weeks. As the chair mentioned, Omicron has arrived, and current evidence shows that Omicron is more transmissible than other variants, infecting roughly 4.5 times more people than each Delta case, based on provincial evidence and data. We also know that Omicron itself has shown dramatic and rapid increases, with estimates of doubling time around 2 to 3 days. And we know that as a variant, it is more likely to reinfect someone who has already had COVID relative to previous variants. And finally, is more likely to infect people who are vaccinated relative to other variants, especially those who have 1 or 2 doses of vaccine on board. So there is, however, some good news that's emerging, showing that a 3rd dose of vaccine appears to provide good protection against severe disease in most people. And in general, we are also seeing that Omicron is less likely to lead to severe outcomes, things like hospitalization and ICU admission, relative to that which was seen with earlier variants. However, despite being less severe from this perspective, Omicron is absolutely causing significant burden on the healthcare system. It is very transmissible and therefore results in a large number of cases. So we are seeing that impact on our healthcare system, which is further compounded by the impact of Omicron illness directly on healthcare workers themselves, which of course puts even further pressure on the healthcare system. And I know that you will have heard much of this through media reports. So looking overall, we know that the sudden surge in Omicron did lead to the province having to implement some changes to eligibility and testing. And these changes in eligibility to testing in turn have impacted local public health's ability to report out on indicators that we had been reporting out over the course of the pandemic prior to the arrival of Omicron. And this includes case counts. So as of December 31st of last year, lab testing for COVID was prioritized for those symptomatic individuals at increased risk of severe outcomes, and for those who are living and working in the highest risk settings and sites, including hospitals, long-term care homes, retirement homes, and congregate living settings. So this then has altered, obviously, the presentation of our monitoring dashboard, which you see on the slide in front of you, because the monitoring dashboard has been affected by the changes to testing eligibility as implemented by the province. So in particular, we've seen that we're not able to provide in quite the same way the 7-day moving average of cases, because it is impacted by the testing changes, as is the incidence rate of the weekly incidence rate of new COVID-19 cases, I should say. We have also had to suppress the reproduction number, which is normally seen on the monitoring dashboard at the center of the slide. Because, without more fulsome case data, the reproduction number can't be calculated as it had been in the weeks and months prior to the changes to the testing eligibility criteria put in place by the province. But I can tell you, as we were about to go through the dashboard, I think it's important that in general, that the board recognizes that all of our indicators that were illustrative of the incidence of cases, they were all dramatically increased prior to the changes to the testing guidance was put into place by the province. And the number of new cases per day was by far the highest it had ever been, as were the percentage of tests that were positive. even as we were going into the earlier parts of the Omicron surge and before the testing changes were made. So turning now specifically to the monitoring dashboard, and just to give you a sense as to how it has changed since we last had a meeting here of the Board of Health. You can see at the top left of the slide that the 7-day moving average for new COVID-19 cases is now sitting at 1,845. Interestingly, at the time we last met, it was 102. It did go up as high as 3,788 on December the 31st. We can see top middle of the slide, weekly incidence rate for new COVID-19 cases currently sitting at 597.4. Early in December, when the board last met, this was more in the range of 23.7. It did increase to 836 per 100,000 population the week of December 26. And as you can see here, it's now at 597. Looking at hospitalizations, that's at the top right hand of the slide. The 7-day moving average is now sitting at 29.3. And I should be clear, these are data as of January 12th. Back when we last met, for the last Board of Health meeting, it was at 1.9. And by January 7th, it had gone up to 31.9. So a slight dip here to 29.3. And of course, we've seen a number of outbreaks of COVID-19 within institutions in particular, affecting our healthcare institutions. You can see here now sitting at 234. At the last Board of Health meeting, it was actually sitting at 2. So you can see the significance of the changes that have happened over time. And looking just as a bit of an update on outbreaks in healthcare institutions in the city, it has dropped down. It's 234, as you'll see here on the slide, on January the 12th. But on Friday, January 14th, we were reporting 199 active confirmed outbreaks within healthcare. So that's where we are currently sitting in respect of the monitoring dashboard. Turning to the next slide, just to summarize, epidemiology overall in broad strokes. Clearly, what we're seeing is the continued rise in respect of hospitalizations and ICU admissions, and of course, outbreaks. Yes, within healthcare settings, but as well in other settings throughout our community. As I mentioned in my earlier remarks, early evidence does suggest that Omicron provides for less severe illness relative to Delta, but it is clear that it can still result in serious health outcomes, particularly amongst those who are unvaccinated or under-vaccinated. And that gets to the final point here on the slide, which speaks to the third dose and the benefit of the third dose in terms of reducing the risks related to, yes, infection, but especially hospitalization, ICU admission, and death from Omicron, the more serious outcomes associated with Omicron infection. Turning to the next slide, a little bit more again from an epidemiological perspective. Here we have a graph that shows the change in both the number of PCR tests per 1,000 people in Toronto, that's depicted in the purple bars on this graph, and the percentage of people, I should say, testing positive, and that's depicted on the blue line in the graph in front of you. And to be clear, these are data as of the week ending January the 8th of this year. So based on this graph, you can see that we saw a large increase in both indicators at the beginning of December. You can see that towards the right-hand side of the slide, with over 2,500 tests per week per 100,000 population and percent positivity topping 30%. And taken together, this really does suggest widespread disease. I'm sure that each of you on a more personal level actually probably experienced in the month of December, towards the end of the year, personal knowledge of people who were actually COVID positive or who became ill with COVID. Again, manifesting in a more personal way what we did see as widespread disease activity in our community. There's since been a decrease in both of these measures after the change to the testing guidelines. And, based on the data that our EPI team looks at, a small early sign of hope with a decrease in our most recent percent positivity to 23.8% amongst those who are eligible to be tested. So of course, we are continuing to watch this along with all the other indicators that are available to us. I think it is important to note, though, while this decrease in percent positivity may be interpreted as a good sign, it does require some caution in its interpretation. The population who can access testing has changed. And while this may reflect a decrease of positivity in the broader population overall, we can't yet be sure at this point in time. So this is something that will continue or will need our continued monitoring over the next few weeks before we can really land more definitively on what is specifically happening and whether in fact we're seeing some positive, whether those positive signs do bear themselves out in a more sustained way. Turning to the next slide, we have a graph showing the 7-day average of new hospitalizations and new ICU admissions amongst Toronto residents in the Omicron surge relative to other waves of this pandemic thus far. Just a reminder that hospitalizations and ICU admissions are lagging indicators. So they are a little bit slower relative to actual disease activity and are likely to continue to increase over the next little while. So another point to note is that our graphs and the counts here actually reflect data on Toronto residents, many of whom, but not necessarily all of whom, may be hospitalized in Toronto. So again, this is reflecting data specifically to Toronto residents, but isn't necessarily a complete indicator of local hospital capacity or occupancy. And finally, I think it's important to note that us at TPH, we include those patients we've assessed and confirmed were admitted directly because of COVID-19. And there certainly has been a lot of discussion on this topic recently. Important to note that all hospitals in Toronto and around the province are, struggling to manage large numbers of people who are admitted to hospital for reasons other than COVID-19 per se, but test positive for COVID-19 on arrival, and therefore have to be treated, with particular infection prevention and control protocols, and that those protocols do add extra strain on capacity. So interestingly, I think, what we see here is that the data may indicate that Omicron is less likely to lead to hospitalizations than Delta, I should say, as seen in the spring of this year. But it is important to note that the sheer volume of cases is causing significant strain on our hospital systems. Again, a story that has been carried by major media outlets, and I suspect lived and experienced in a more personal way by members of the board who are directly connected to the healthcare system and have had the opportunity to witness this. So, I think that, we are obviously heartened to see that hospitalizations and ICU admissions, do appear to be lower relative to previous waves, but that isn't to take away from the fact that there is significant pressure on the healthcare system at this point in time. I think other points that are worthy of note here is that we are overall seeing significantly shorter lengths of stay this time around relative to what was seen in previous waves. And I think it's important to note that one of the key differences between now and earlier waves, particularly in the spring, is that so many of our residents, so many people in Toronto are vaccinated. We do know that 3 doses of vaccine are the best defense against Omicron, and particularly against Omicron-related hospitalization. Turning to the next slide, let's now turn to another method, a discussion of another method by which to assess local COVID-19 activity, and that's wastewater surveillance. This is a method that's meant to complement traditional COVID-19 surveillance, and it is a relatively novel tool recently implemented around the world to help our understanding of the true presence of COVID-19 in a community using a method that's independent of clinical testing. So what's good about that is that it doesn't rely on obtaining lab confirmed diagnoses and therefore is less influenced as a result by such things as test seeking behavior or testing rates or access to testing, which we know from previous experience plays a role in respect of actually getting clinical test results, PCR results, for example. So there are these assays that have been developed to detect and quantify concentrations of SARS-CoV-2 virus, the virus that causes COVID-19, in wastewater. And these assays are used to help in terms of providing us additional situation awareness on the burden of COVID-19 in the community in a method that just may not be captured by routine surveillance. So as you can see on the slide, we have collaborated with academic partners to implement a pilot to understand and validate this method of surveillance. And what we have figured out thus far is that it does correlate with clinical data. We haven't noted that it's been particularly valuable as an early warning system, however, but it does really show some potential as a confirmatory tool, by which, or a tool to confirm increased or decreased trends, particularly when used in conjunction with other data sources. Let's turn to the next slide so you can actually see a little bit of what we're seeing at this point in time. And these are data, the most recent data summarized by our provincial colleagues at the Ministry of Environment, Conservation and Parks. And specifically, we're looking at data for Toronto's 4 wastewater treatment plants, as well as some clinical data. Just a few important points that are worthy of note here. One, we are indeed served by 4 wastewater treatment plants, but they do not serve equivalent proportions of the city. For example, you'll see that the 4 named plants, Ashbridges Bay covers just under half of the entire city. The Humber plant covers about 24%, Highland Creek about 17%, and North Toronto roughly 8% of the population. So again, these are not covering equivalent components of the city. But just so you can understand and see what we are seeing based on this presentation of data provided by our Ministry of the Environment partners. As I mentioned, the left side shows the case data trends for populations, and the right side shows the wastewater COVID virus signals since early December for the same areas. You should note that these are data, that these data have been graciously, if you will, smoothed out by our colleagues at the Ministry of Environment. The way the wastewater signals actually present in the raw form, as it were, is there's a lot of variability. And what they've done is used appropriate data methodologies to smooth these things out. You do see that wastewater results can vary by watershed source. The testing is a little bit different in terms of timing from one place to the other, but overall, what we can say is that through this source, we can see that retrospectively, there's good correspondence between case surges and signal in the wastewater data. And perhaps most interesting for us looking forward, there may be evidence of a potential plateau or even a decline in virus detected at the 4 watershed sites. That's very early on, and we're looking to confirm this with our complementary data sources, and will of course continue to monitor to see if the trend continues. I do want to point out that our plan is to try to translate this complex wastewater data into a format that is readily accessible to the general public. And we are planning to have that up as part of our reporting on a regular basis as early as next week, but wanted to make sure that the board had the chance to take a look at what we are seeing at this point in time and how we are using these data to inform our understanding and situational awareness of what's happening on the ground. Turning to the next slide, we're now moving to the component of the presentation that provides an update on COVID-19 vaccination. So let's turn to the next slide specifically so you can see graphically a representation of the share of Toronto residents aged 18 plus who are vaccinated. It's important to note that Team Toronto, that's the full team of vaccination partners across the city, have thus far administered 6,247,627 doses of COVID-19 vaccine in Toronto since the campaign began in late 2020. You may recall that very first dose of vaccine was given in Ontario on December 14th, 2020. So we are awfully close to 90% of our residents 18 plus being vaccinated with one dose and have over 40% of our residents 18 plus vaccinated with 3 doses. Again, if we're looking at the figures for those who are eligible, it's actually closer to 50% of 18 plus, our 18 plus population, excuse me, that has had a 3rd dose. So just to give you a sense as to what further needs to be done on the vaccination campaign in order to reach 90% coverage with at least 1 dose for the 12 plus population, about 6,000 people need to be vaccinated with their 1st dose. And this is a reflection of data as of January the 13th. Similarly, in order to reach 90% coverage with at least 2 doses for the 12 plus population, it's roughly 85,000 people who have yet to be covered. So we do know that there is work yet in front of us, but I think by the same token, we should be looking back on just how much has been accomplished in the vaccination campaign in a relatively short period of time. Almost 6.3 million doses of vaccine administered in just a little over a year. Just, never done before in the history of this city, and really something that I am extremely grateful to all of our vaccination partners and our own staff for this achievement. Turning to the next slide, just to give you a sense as to 3rd dose coverage for those 50 years of age and older, again, age being a risk factor for more severe outcomes associated with COVID-19 infection. You can see here that we are, doing what we can to increase dose 3 coverage amongst all eligible age groups. There is, however, still some work cut out for us as vaccine partners throughout the city in order to make sure that people are getting the benefit as much as possible of vaccination. Speaking of the benefits of vaccination and increasing that coverage and learning from previous experience, turning to the next slide, this is to give you a depiction of what we are seeing in respect of the coverage rates of vaccine and how it is emerging across the city. We have noticed this. You had heard me speak to this before in weeks and months gone by, but as seen with previous rounds of vaccination, not unexpectedly, but yes, unfortunately, we are seeing a disparity in coverage by neighborhood. Here in this map, you see the percentage of the total population aged 18 plus who've received a 3rd dose by neighborhood, with the neighborhoods that are shaded in the darker blue color having greater coverage, and the lighter the shading, the less the coverage in respect of that 3rd dose amongst those 18 plus. We know that lower vaccination rates in some areas will reflect a mixture of things, including access, absolutely, and as well, some degree of hesitancy or lack of confidence in vaccination. And we know as well that there are many, many reasons underpinning this, some of which are historical in nature, cultural, there are contextual factors, particularly amongst communities that have experienced systemic racism and discrimination, and especially in their interactions with the healthcare system. But please know that Team Toronto, with the network of community agencies and vaccine ambassadors, has been working hard to increase vaccine acceptance and availability and ultimately uptake in areas of the city where vaccine coverage is lower. And I'll have more to say about that, including on the next slide, talking about our community vaccination strategy. And what it is that we are doing as Toronto Public Health in concert with our partners to expand opportunities, whether it's through more vaccine appointments, more walk-ins, yes, at mass immunization clinics. We know that these are settings that are particularly good at driving up large volume vaccinations, but we also recognize that other methods have to be used in order to reach certain populations, particularly those that are shown in the map from the previous slide to have lower levels of coverage. Things like pop-ups, mobile clinics, working with pharmacies, and yes, working with physicians in the community. We are absolutely as well seeking to provide more equitable vaccine access by bringing vaccine to particular neighborhoods and communities, and using a number of strategies that we have developed over the course of the last year of the vaccination campaign. And we know that these things do work. Things like hyper-local vaccination clinics, so very focused vaccine clinics, dedicated appointments in clinics for particular neighborhoods. So the kinds of things here are things like making sure that vaccine clinics are available in, for example, Toronto community housing buildings. We did 24 such buildings in December, and we have 73 more scheduled thus far for January and February. And of course, we continue to work with our vaccination partners to do more of this. School-based clinics, I'll speak a little bit more about this a little bit later in the presentation, but I can tell you that we've had approximately 250 school-based clinics since November, and more being added. Special event vaccination clinics, community-based outreach to make sure that people are hearing information and are aware of vaccination opportunities, but hearing in particular from local leaders and agencies with whom there already exists a trusting relationship. So a number of different methods and approaches being tried to make sure that equitable vaccine access is top of mind, and really what's being reflected in our practice to the greatest extent possible. We have 155 community agencies on the ground, 410 community ambassadors involved in outreach. Really every effort, including technological ones, using email, text, phone calls, to make sure that people are aware of the opportunities to get vaccinated. Turning to the next slide, just further characterizing the prioritization that together with our vaccination partners, we are undertaking to make sure that neighborhoods where we know coverage needs to improve significantly actually are getting the efforts and attention paid that they need in order to make sure that that vaccination coverage goes up. So I will turn to the next slide as we start to speak about specific communities and areas so that the board has a sense as to what it is that we are doing to increase coverage, particularly in areas where we know it is more challenging, or it has been more challenging, to drive up vaccine coverage. So for example, we are working with our partners to maximize access and opportunities for vaccination in congregate settings. And this includes places like shelters and long-term care homes. As you can see on the slide, we've held a series of clinics at shelters, over 1,300 vaccination clinics, some of which we have participated in directly as Toronto Public Health. Others have been more led by our vaccination partners, but certainly have held as many clinics as we could, and repeated, in fact, many clinics to ensure access, whether it's at shelters, 24-hour respites and drop-ins, many doses delivered as a result. And certainly my thanks goes out to the partners who've been engaged in that. We have bolstered these vaccination opportunities through the use of incentives, whether it's through cards for Tim Hortons, for example, I know was one that was used and was something that we consulted with shelter clients on to ensure that the incentives were meaningful and of value to clients for whom they were focused on. A peer champion program, vaccine ambassadors, again, with lived experience of homelessness, and making sure that information is readily available through a variety of different sessions and channels and venues. And of course, we continue to support the rollout of third doses to eligible long-term care staff, to essential caregivers in those settings, volunteers, students, and residents. And with the recent direction from the province, this also includes support of rollout of fourth doses to eligible residents within long-term care homes. So we are making progress. I know that we heard particularly, for example, from our city long-term care run homes, as I understand it, they are over 90%, more in the range of 92% of residents in those city directly operated homes who have actually got 3 doses on board, and they are working their way through the 4th doses, which I understand is also going and proceeding very, very well. Next slide, a little focus on vaccination for children and youth. As of January 13th, I can tell you that we are continuing to keep planning clinics for children and youth. We are focusing obviously on those who are 5 to 17-year-olds who are part of our school system. We have, as I mentioned earlier, more than 250 school-based clinics delivered since November, more than 40 planned through to the end of this month, so in the next couple of weeks, and more being added all the time. It's interesting to note as well that provincial direction last week requires that school boards and local public health units work on school-based clinics, particularly during instructional hours. We were already doing school-based clinics, as I've mentioned, more than 250 since November, but we are working now in light of the new direction from the province with our school board partners on expanding the hours. We had done our school-based clinics to date with a little part of it, overlapping with instructional hours because they were occurring towards the end of the school day and then after school. But with new provincial direction, we are looking at expanding the clinics that are occurring during instructional hours, again, as per that recent direction. Important to note, though, if I can go to the next slide, that we have gone to great efforts along with our vaccination partners, and hopefully, as you can see here on the slide, to ensure that our school-based clinics, our youth-based clinics, including our school-based clinics and our non-school-based clinics, are actually really getting to those parts of the city where we need to drive up coverage. So you'll see here that this is a slide that depicts the general vaccine coverage for the city by neighborhood. As mentioned earlier, the darker shaded areas are those where the vaccine coverage is higher. The lighter shaded areas where vaccine coverage is lower. And you'll see that the preponderance of our youth and children focused clinics actually did occur and will continue to occur in those areas of the city where we know vaccine coverage continues to be a challenge. This is not something we're doing alone as Toronto Public Health. We are doing this in concert with our Team Toronto partners. And as I mentioned, we are working together to ensure that coverage, vaccination opportunities, I should say, are as available as they can be, particularly to parts of the city where we know coverage has been a challenge and access in general has been a challenge. So I would just like to take this moment to acknowledge the efforts of, yes, the team at Toronto Public Health, but of course the other Team Toronto vaccination partners for all of their work in this regard. Turning to the next slide, there are going to need to be continued efforts to maximize vaccination uptake. So you'll see that I have in this presentation before you some recommendations that we are making to the Board of Health. The first two, I should say, are really directed more towards us at Public Health, seeking that the board support us in our plans to accelerate the hyper-local vaccination strategy in order to maximize opportunities for vaccination, particularly in those parts of the city where vaccination coverage is low. The second is to echo the support or support us at Toronto Public Health in our efforts and our interests in exploring methods by which to incentivize vaccination against COVID-19 on an ongoing basis. Looking further at the last two recommendations on the slide, they are more focused towards requests to the province of Ontario. The first, to enhance and expand programs and measures to increase vaccine confidence, particularly amongst parents and caregivers of children and youth, and indeed to children and youth themselves, so that they can then get the protective benefit and increase the coverage for the protective benefit of COVID-19 vaccine. And the final is to request the province of Ontario to facilitate access to vaccinations by allowing for the booking of third doses where out-of-province vaccinations are not yet entered, similar to what is currently being done right now for 5 to 11-year-old clients without OHIP. So again, all of these recommendations geared towards maximizing vaccination uptake, both now and into the future. Turning to the next component of the presentation, and I promise we're getting close to the end of the public health component, supporting the safer reopening of our schools. Turning to the next slide, the plan was under the provincial direction to have children return to in-person learning in class today. Mother Nature through snow clearly had a slightly different plan. But that, as far as we understand, is a temporary deviation, if you will, off what the province had worked on. I think it's important that the board recognize that there is a great deal of research, both locally here in the province and from other jurisdictions, that actually shows the benefit of in-person learning, the significant benefit of in-person learning in respect of children's health, both physical health, mental health, and overall social development. There is a very, very important part played by in-person learning. I will just very briefly touch on a few of these things. The Ontario COVID-19 Science Advisory Table, and if I can just quote from them, notes that Ontario evidence shows that school closures are associated with substantial mental health and educational attainment harms. It speaks of the cumulative nature of these risks and also points out that they are in fact disproportionately experienced by those families and children that are from already more marginalized, racialized, and hard-hit groups in respect of COVID-19 itself. We do know that further, looking at the data from both Public Health Ontario and the COVID-19 Science Advisory Table, that Ontarians are aged 5 to 19 years, particularly those that are vaccinated, appear to be at low risk for hospitalization and severe disease from Omicron compared to other ages. And this, again, was nicely displayed by the Science Advisory Table on their most recent public release of information on this particular issue. And I think that what they also pointed out in their most recent paper on this, they talked about how closures of in-person learning have a smaller effect on community spread of SARS-CoV-2 compared to many other public health measures. So it'll be interesting as well for the board to hear, and I'm sure if you reflect your mind or cast your mind back, you have had over and above this information that was recently put out by the Science Advisory Table and by Public Health Ontario. You have received presentations in the past from people. I think of Josh Fullen from Maximum City and the extensive survey work that he has done with children and their families in and around school closures and moves to remote learning. And certainly the kinds of things that were described in the recent evidence documents from the Science Table and from Public Health Ontario were echoed on a more local and personal level by the survey findings through Maximum City and some other parties that have done this kind of work. But with respect to the return to in-person learning and the recent decisions taken by the provincial government in this regard, there has been new direction released specific to what local public health is meant to do in partnership with the school boards and the schools themselves to support safer learning environments for our children and of course for the staff who work there. So turning to the next slide, you'll see in a chart format the nature of the changes to the role for Toronto Public Health under the new provincial guidance. So you'll see that we have had largely 4 major roles. Those are articulated on the left-hand side of this chart. And you can see that there were certain ways in which we manifested those roles under the fall guidance from the province and now under the new winter guidance that has just been issued by the province. And you'll see that for many things, our role with the schools and school boards will continue when it comes to things like liaison, recommendations and advice on infection prevention and control and other measures to mitigate COVID-19 transmission. That will continue on. Vaccine education will continue. And in fact, we are going to enhance that to the greatest extent that we can so that people are more readily taking up the protective benefit of vaccine. Vaccine clinics, of course, are continuing. And in fact, we're enhancing, as indicated here on the slide, making more clinics available as much as possible to the school community and making sure that we're expanding our focus now to a 5 to 17-year-old population, whereas earlier in the fall, it was largely focused on 12 to 17-year-olds, as you know, vaccine for 5 to 11s was not available until quite late in the year. And then finally, you'll note that there are some changes in respect of case contact and outbreak management. Our role here is limited, given the changes to testing. However, of course, we will continue to support and provide guidance to schools and school boards as per the provincial direction, you know, if there is absenteeism above a certain level within the school community itself. So we are in regular communications with our school board partners and to schools, again, to varying degrees, making sure that we're doing the best we can under the current guidance to provide the necessary support. Turning to the next slide. So you'll see that, yes, our role has shifted a little bit and in some cases is being enhanced, but certainly we continue to have our commitment to promoting a safe and healthy learning environment. This has always been the top of our priorities when it comes to school. And I would just ask that, of course, while there is a role for Toronto Public Health, we all have to make every effort to help keep schools as safe as possible. So for us, you know, making sure that vaccine opportunities are accessible and are as available as possible and that people actually have the information they need to make good choices around vaccination, we can certainly do that. And of course, we seek the cooperation and collaboration of our public in following public health and infection prevention and control measures in order to support that return to in-person learning. You know, speaking of vaccination, which is, of course, one of the major elements for us, we are focusing on children and their families. We have also gone to great lengths to ensure that education sector workers, including those in childcare, are afforded that ability to get vaccinated. We have run a number of clinics as of late, specifically directed towards education sector workers, and will continue to make sure that they are part and parcel of our vaccination efforts, including those in school-based clinics. But with respect to this issue, we do have one recommendation that I'm putting forward here to the board, and it's that the board requests that the province of Ontario makes every effort to maintain in-person learning, right? In light of the scientific understanding of the importance of in-person learning to the physical, mental health of our students and their overall developmental well-being. And the idea is to make sure that all the measures are put in place to promote safety in schools and in childcare settings. And a number of those measures are actually listed as part of the recommendation, but it's not meant to necessarily say that these are the only ones, but at least to start with these and to continue to look to the science in terms of what makes the best sense for ensuring as safe an environment as is possible within our school communities. With that, Chair, that is the public health component. Turning to the next slide, you'll see I'm now handing it over to Chief Pegg to provide his update to the Board of Health.
And just before Chief Pegg takes the floor, could I ask, Board, I had meant to, at the beginning of the meeting, do the registration cutoff for speakers, the timing. And so obviously we're not cutting it off at 10 a.m. because we have passed 10 a.m. But could I move the motion to cut off registration for 10:50? I would, at the committee's indulgence, I would like to keep the 5-minute time limit rather than 3, given the many important items under debate. But could I move that motion, Julie? Our recording secretary, do you have that?
Mr. Chair, we're just getting that on the screen, Mr. Chair. If you could just give us one moment.
Thank you kindly. And my apologies, I know I had meant to do that earlier. Everybody can hang in suspense before Chief Pegg, the man with buttons, joins the screen.
I'm sorry, Mr. Chair, we are having some technical issues and are unable to show that motion at this time. Did you want to just, for clarity, just repeat that?
I will read it and just by way of a vote, that speakers who have not pre-registered be allowed to register to speak until 10:50 a.m. on January the 17th, 2022, after which no further registration is allowed, and the list is closed. And that does not change the speaking length of time. So that is moved, and I'll call that. All those in favor? That's by way of a show of hands. Any opposed? And I know we have 2 members on the phone. Any opposed? Okay, seeing none. Thank you. That carries. And with that, I will pass the floor back over to Chief Pegg for your section.
Thank you very much, Chair Cressy. Good morning, Mr. Chair, and members of the Board of Health, and ladies and gentlemen. I join you today in my capacity as the city's incident commander for COVID-19 operations. Thank you so much for allowing me to provide this update. We'll go to the next slide, please. I'm going to do my very best to move through this information very quickly. Just by way of history, I'll remind you that the City of Toronto, Mayor Tory declared a state of emergency in the City of Toronto in response to COVID-19 all the way back on March 23rd of 2020. That is and continues to be the City of Toronto's first and only declared emergency. On this slide, you'll see I've listed but some of the members of the Strategic Command Team. In accordance with the city's emergency plan, the COVID-19 Strategic Command Team was struck and is functioning in accordance with Chapter 59. This is really what we would refer to as the approved IMS, or Incident Management System model, that has been approved by the Emergency Control Group to manage COVID-19. And things as we go through, like the Business Continuity Task Force, PP Management Task Force, all of those groups of people, as well as the city's Emergency Operations Center, are all functions of our incident management system. They all ultimately report up to the Strategic Command Team via my role. My principal role is to coordinate those functions. Next slide, please. We are and have been planning and continuing to evolve our plans in response to COVID-19 as the pandemic has transitioned. There's been literally different plans for each of the 4 waves. And of course, now with the emergence of Omicron, we're into yet another planning and response operation. We proactively reactivated the city's Emergency Operations Center on December 16, 2021. That was ahead of the arrival of the Omicron wave in the city. And that included reactivating fully both the Business Continuity Task Force and our Personal Protective Equipment, or PPE, Management Task Force. We'll talk a little bit about those. The Strategic Command Team and our Incident Management System continues to be very effective and efficient in managing our response to COVID-19 in live time. The word of the pandemic seems to be pivot, and that is certainly the world that this team lives within every day. This includes some very robust planning and now response operations with respect to increased levels of unplanned absence from a staff and teammate perspective. So that is what I'm going to focus on for the rest of the presentation, and we'll go to the next slide, please. Heading into and prior to, obviously, the Omicron wave, we had proactively planned across the whole city and certainly across each of the emergency and essential services for unplanned absence rates as high as 40%. And that was really just best practice modeling and some proactive planning we had put in place a long time ago now to make sure that we were well prepared. In response to Omicron, and which of course brings with it or has brought with it some significantly enhanced projections and modeling, we have proactively increased that planning now to deal with up to 60% unplanned absence rates. So those plans are in place. I'm happy to report to you. They are being implemented every day, and I'm going to share with you and hopefully reassure you that we're in good hands. Next slide, please. So this just lists what we view to be emergency and critical services. Our Strategic Command Team every day monitors the staffing and service levels provided across each of these organizations: paramedics, fire, shelter, sport and housing, senior services and long-term care, children's services, Toronto Water, and Toronto Public Health, which of course includes our city-operated vaccine clinics. We are also directly connected on a daily basis with key agencies that include Toronto Police and the TTC. Next slide, please. First and foremost, what I want to assure you and certainly make very clear, our emergency services will continue and in fact are continuing to respond to emergency calls without interruption. So that's been obviously one of our primary goals throughout the response aspect of COVID-19. That is continuing. Each of those services have best-in-class contingency and business continuity plans in place. Those plans are being put in place every day. We're monitoring that, like I said, on a daily basis, and that is all combining to ensure that our city remains safe. I listed on the bottom of the slide just a few of the measures that are in place to give you an overview and a sense as to some of the mitigation tools that we're using. Obviously, very extensive use of staff overtime and shift extensions. And I would be remiss if I did not acknowledge from the outset that our staff and all of the people that are working across the city with the entire Team Toronto effort are going well above and beyond, and have now for nearing 2 years. And certainly my thanks and my respect to them all. We have very robust processes in place with respect to 911 and emergency incident triaging. And those terms really just refer to the fact that we always respond to the highest risk and highest priorities emergencies first. Lower priority or lower risk events at times may wait when we're during times or during periods where we have an increased volume of high risk or high priority emergencies. Dynamic deployment of resources, including staff, are in place across all of the emergency services, as well as some very innovative solutions happening internally with respect to the cross-training of staff, ensuring that we're able to support critical functions and roles within each of the emergency services. So all in all, we're in good shape. Things are working well. Next slide, please. The Business Continuity Task Force is working every day with the city's People and Equity Division and the city's senior leadership team under the leadership, of course, of City Manager Chris Murray. Their principal focus is on the redeployment efforts internal to the city, making sure that we are able to provide critical services and staffing to those critical and essential divisions that require that. So that is work that is happening around the clock every day, and very important part of our response plan. As well, the Personal Protective Equipment, or PPE Task Force, continues to manage all aspects of PPE. Most recently, that has been expanded to include rapid antigen tests. And very happy to say that the rapid antigen tests, the initial deployment of those have been distributed to our top priority service areas. That includes emergency and critical services, and distribution is now underway to the next tier. So a lot of great work happening there. And of course, continuous collaboration, both at the political level and the staff level, with both the province of Ontario and the government of Canada. Next slide, please. And this is my last slide. Just to give you a sense as to how well these plans are working. Implementing the mitigation plans across emergency and essential services, we have been able thus far to successfully reduce the unplanned absence rate from 17.6% on average daily down to an operating average through mitigation of 12.2%. So that gives you a sense as to how well, how well those plans are working. Emergency services are continuing to deliver very effective service. As you've heard, and you're certainly aware, the healthcare sector continues to be challenged. There's no doubt about that, both by unplanned absence and increasing demand. That is the key and principal challenge within our paramedic service right now, is the situation known as offload delays, or the amount of time that is required for an ambulance and paramedic crew to transfer the patient they're bringing into the care of the hospital and then clear and be able to get back on the road and respond to the next emergency. So that is being managed. Chief Raptis, the Chief of Toronto Paramedic Services, is in direct and daily contact and connection with each of the hospitals. And the last thing I will just bring to your attention is the focused staff redeployment. So those things are underway. We are prioritizing redeployments to support shelter support and housing, senior services and long-term care, children's services, and our city-operated COVID-19 vaccine clinics. So I will just say, Mr. Chair, I will say thank you very much to you and to the Board of Health for your leadership and your support throughout the COVID-19 pandemic. I am honored to work alongside each of you as we navigate through this, and I am 100% confident we are going to beat this thing and come out the other side. So thank you very much, sir.
Thank you, Chief Pegg, and welcome, and thank you again for joining the board, as you've done many times through this. Members, we have one more person speaking with us today. It is a shorter presentation, as we are moving to public deputations after. But I'd like to invite our Deputy City Manager for Community and Social Services, Paul Johnson, who recently joined the city. So welcome to the board for the first time, to give an update on the community response within the city. So Paul, over to you.
Well, thanks very much, and to you, Chair, and the members of the Board of Health. It's great to be here. I am just going to spend a very few minutes talking a little bit about some of the response, not only to the pandemic, but also to the other community needs that are out there during this time, of both the services that are within the community and social services realm at the City of Toronto, but going to end my comments by focusing very much on the work we're doing in partnership with literally hundreds of community organizations and support. So if we move to the next slide, this is not a comprehensive list of our response, but I thought I'd give you a bit of a flavor of how some of the services here at the City of Toronto are responding and continuing to respond, not only to this pandemic, but working in partnership with community, who of course help us deliver some of our critical services. And it starts in children's services. Childcare and early learning, yes, has some direct operated programs through the City of Toronto, but the majority is delivered by community partners. And we are seeing, obviously, the constant change and pivoting, as to use the word of the day, of this sector. It's great to see almost 95% of the centers open. The capacity is coming back slowly and will take some time, we know. But again, last week alone, 600 children, give or take, accessed emergency childcare for the week that school was out and emergency childcare was available. That allowed not only children to be in high quality early learning opportunities, but their parents, families, caregivers to be back at work. This week, we will be focused on rapid test distribution to childcare programs that's happening through the ministry, who's asked municipalities to take on that leadership role. But that's over 600 programs that we're going to be delivering rapid tests to. And we continue to ensure that the sector maintains a safe operation. Economically, it's really critical that our Economic Development and Culture Division has been working with businesses in a variety of ways, and whether that's programs like Cafe TO and other initiatives that have supported businesses to operate safely and continue to operate, or whether it's the rapid test distribution that's been happening for a number of months and is waiting for some supplies to come now, but we hope to get back into that business. It's all about that connection to business so that we can work with business owners. In fact, there's a one-to-one support opportunity available for businesses who want to navigate this complicated world of the rules in terms of how they can safely operate, but also access some of the many programs that are out there. For those who require income security and income support, our folks have been there online and on telephones to support those who need it. And as some of you may know, there has been a surge of applications for social assistance through Ontario Works program over the last couple of months, and we've supported that. We continue to be there. And for those who do still need to come in person, it's a small number now, but our staff are on the front lines delivering those services as well. Next slide, please. We've talked a little bit about the shelter services through Chief Pegg's update, and we continue to both expand the system as we deal with the pandemic, but also with winter weather, and continue to find new ways to protect those who work and those who reside in our shelter system, including the distribution now of N95 masks to both staff and residents within the shelter system. In long-term care, it's really been focused around continuing to keep those residents safe. And you've heard a little bit about this from both Dr. Davila and the Chief. So I'll focus on that final bullet point under long-term care. What I've really been impressed with is, despite staffing constraints and all the rest, our staff in our 10 city-run long-term care facilities are working very hard to support enhanced numbers of virtual visits, connections in any way to those who want to visit with their loved ones, but unfortunately cannot in this particular moment actually physically access those facilities. So I thank them for that. Next slide, please. And finally, I just want to touch on parks, forestry, and recreation. While we all move through this pandemic, the ability to engage in activity, be that in exercise, be that in ways of just getting out and in some ways trying to push this pandemic out of our mind for even a few minutes, has been critically important. And yes, the indoor activities have started and stopped along the way, but I think it's important, even in this period of time where indoor programs are closed, to remind the board and the public that there are lots of opportunities for getting outside. And yes, today will be an exciting opportunity for people to get out and do all sorts of things in the snow. And yes, I know some of our programs are not open today because of the fact that staff are having trouble getting there. But in a normal course of business, and I'm sure we'll be back up and operating by tomorrow, there are just so many opportunities for people to get outside in relatively safe environments, much safer to be outside than inside, and enjoy all sorts of different activities, from those that are heavy on the exercise front to those that are a little more passive and just getting outside and enjoying outdoor activities. Next slide, please. One of the really impressive things that I learned about joining the City of Toronto is just this whole TO supports program that has been going on since the very early days of the pandemic. This slide goes through, and I'm not going to go through each one of them, but this slide goes through the things that were enacted early on in the pandemic and continue to operate today. Some have been reconvened more recently, such as the City Community Response Table, because there are certain needs that we need to look at as we work through Omicron and this latest wave in the pandemic. But all of these actions have occurred throughout the pandemic. They continue to be supported by a variety of city staff, but more importantly, continue to be delivered in partnership with community. And whether it's in the vaccine programs, whether it's in our supports for isolated individuals, the food security needs of this community, I can't thank the community enough for the way they have stepped up and worked in partnership with the City of Toronto. Next slide, please. So more recently, we asked our community partners what is happening on the ground in this particular moment during the pandemic, and we heard a few things. They are consistent with what we've been hearing through the pandemic, but we wanted to make sure that things hadn't changed. And of course, residents in vulnerable circumstances continue to struggle to meet their basic needs. So stepping aside from some of the things they need to do in terms of COVID-19, the very demands of daily living, if you're in a vulnerable circumstance, continue to be there. There are very much concerns. That last bullet point in that first piece is one we're hearing more and more about, concerns about vulnerable children being left behind. We're also hearing that the community service sector is struggling as well. As this pandemic continues to go on, the for-profit businesses as well as our not-for-profit businesses are being deeply impacted, and their ability to continue to deliver service is being stretched at the moment. And of course, we need to help our residents stay healthy through this period of time. And we continue to see that as a huge need, both providing the access to vaccine and boosters, but also making sure that they have protective equipment available to them as well. Next slide, please. And so our work in the coming days and weeks will be around three priorities, and those very much link with the last slide that I talked about. And so some of those next steps are, of course, making sure the resources that are in place already are activated and initiated so that we can meet some of those needs. And that is, of course, some of the cluster work that's happening and getting these tables back together, looking at the policies around our rent bank and extending the ability of a rent bank that it does have funding in order to support folks. But on top of that, we will be looking and exploring, and we are this week, additional resources to enhance particularly the areas of food security and ensuring that our community partners can continue to deliver service. So again, I'll close where I began and thank our community partners so much for their interest in stepping up and working alongside the City of Toronto, and also thank the Board of Health for its continued work at prioritizing the broad array of supports that are required to keep people healthy in this community alongside those targeted efforts to deal with this pandemic. Thanks so much.
Well, thank you very much.
If
yes,
I may, there's just one last slide in the presentation.
One last slide. You got
one
it.
last, and I promise I will keep this brief, but it is important, Mr. Chair, for the whole board to recognize. And I'll thank first my colleagues, Chief Pegg and Deputy City Manager Paul Johnson, for their presentations. I do want to note that we are, today, January 17th, and we are almost now 2 years since the first case of COVID-19 in Toronto, that being on January 25th, 2020. And this has been an incredible and an immense collective challenge for us all. We've had thousands, hundreds of thousands of cases across the province and here in the city. And we know that here in the city alone, we have lost 3,818 of our community members to COVID-19. At an organizational level, Toronto Public Health has been deeply, deeply affected by the pandemic these last 2 years, which has touched all of us personally as members of this community, but also completely consumed our professional lives and truly upended our entire organization. But I will say this, both at Toronto Public Health and more broadly as a community, I look back and I see that we've risen to many, many challenges collectively and accomplished many things, putting us in a much better position than we were 2 years ago. We know that masking and distancing help prevent transmission. And we now have these incredible vaccines that provide strong protection against serious outcomes. I just briefly want to touch on that because we see the impact of vaccination when we look at the most recent province-wide data, looking at outcomes between vaccinated and unvaccinated individuals. So looking specifically at cases between December 24th and January 6th, the rate of hospitalization for unvaccinated individuals was roughly double that of individuals with 2 doses of vaccine and 4 times that of individuals with a 3rd dose of vaccine on board. And when you look at ICU admissions, the outcome was 3 times higher amongst unvaccinated individuals relative to those with 2 doses on board, and 8 times higher than those with 3 doses. So we do see significant impact associated with vaccination. Our knowledge of and our ability to fight COVID-19 comes down to this knowledge that we've gained, and fundamentally to the really incredible and inspiring efforts of so many people around the city. Public health staff, for sure, healthcare workers, researchers, scientists, essential workers, and frankly, every person in the city who has done their part and continues to do their part by getting vaccinated and following public health measures. You know, for these efforts by this large group of people across the city, I can only offer my most sincere and heartfelt thanks, and just one parting thought for today, which is that it's clear the pandemic is not yet done. But I am heartened by the fact that I believe we have the knowledge, the tools, and the collective will to get through this together. So with that, Mr. Chair, I will now hand it back to you and thank everybody for their attention.
Well, thank you, Dr. Davila, Chief Pegg, and Paul Johnson, and to members of the board and the public watching. I know that that was a full and comprehensive and long series of presentations, but it gives you a sense of both the breadth and scale of work underway, and I think is critically important context for everyone to have, especially members of our board, as we move into this item. We're now going to move into...
Sorry, Chair Cressy, just on point
Yes.
of order, Councillor Ainsley.
Yes,
I couldn't write fast enough as Dr. Davila was giving those stats between, I believe it was just after Christmas and into January. I was just wondering if we could have those stats emailed to us so we could, I think they're very important to have on hand if we are talking about people and why they need to get vaccinated, if we could have them sent to us.
Absolutely. Consider that an important point of order and one which we will action right away.
Thank you. Sorry to interrupt.
Not in the slightest. Thank you, Councillor. So we'll move into public speakers. We do have a series of speakers who are registered, and speakers in advance, you'll have 5 minutes to speak, and then we'll see if there are questions from members of the board. Members of the board, as a time check, I anticipate that we will be breaking for our lunch recess at 12:30. Closer to that time, I'm going to suggest that we break for 30 minutes rather than a full hour as we have a number of speakers. But I'll just say that as a heads up for planning. So let's move into speakers. We've received a request. One of our registered speakers has to leave imminently. And there's been a request from the president and CEO of Sick Kids Hospital if he could be permitted to speak first. And with the concurrence of the board, I would like to allow that. So our first speaker is Dr. Ronald Kahn from the Hospital for Sick Children, Sick Kids. Do we have Dr. Kahn on the line? Nahom, I'm just wondering if you could connect to see if Dr. Kahn is available.
Muted. Can you hear
To
me?
the chair, that is the speaker connected and now unmuted. Thank you.
We have you and we can hear you, Dr. Kahn. Welcome. Thank you for joining us, and you can begin when you're ready.
Okay, good morning, Mr. Chair, members of the board. Thank you very much for the invitation and opportunity to briefly speak with you today. I will speak about 2 items, about children in school, but also about what we are and have been learning around Omicron impact on children's health. So I think we know and all agree by now that in-person learning is essential to the mental, physical, and developmental well-being of children. But I'd like to emphasize a couple of things that are sometimes not part of the whole discussion that, for example, children and youth with disabilities are losing access to in-person school-based rehabilitation services when schools are closed. And many children will lose their access to food programs. And the other aspects that has become even more important during this current wave is that parents, and unfortunately mostly female parents, that often include essential workers, are missing work and with that important family income. And if you look at the last almost 2 years, Ontario schools have been closed over 27 weeks since March 2020, longer than any other jurisdiction in Canada, and honestly longer than most of European countries. And we now have international data that shows a decline in student achievement associated with pandemic-related school closures and the online learning associated with this. We also have Ontario data that shows six-fold increase in extreme student absenteeism. That's characterized by more than 50% of absence of classes, particularly during the pandemic. And as you have heard in previous presentation, school closures also disproportionately affect low-income families, essential workers, racialized groups, and other marginalized communities and people with disabilities that are already hard hit by the hardships of the COVID-19 pandemic. And one of the main concerns we have is that our school closures increase social isolation, which is, as some of our research and research from colleagues across the world have shown, is a major contributor to worsening of children's mental health. And a study particularly of children here in Ontario between 6 to 18, which looked at children who did not have any pre-existing psychiatry diagnoses, demonstrated an increased clinically significant symptomatology of depression and or anxiety. And the proportion of children with clinically significant symptoms of depression and or anxiety nearly tripled during the COVID-19 pandemic, from 1 to 4 for depression and 1 in 5 for anxiety. And I can tell you just from my personal experience at Sick Kids, our inpatient mental health unit that really takes care of some of the most severely affected children has been operating at 110 and 100 to 130% capacity really throughout this almost entire time. But I'd like to take a couple of minutes before I end and speak about the clinical impact of Omicron on children. Now, I would like you to know we have and continue to meticulously monitor the clinical features of children who become infected with the Omicron variant over the last few weeks. And we are in regular contact with colleagues in Europe, the United States, and Israel to learn from their experience. And what I can say as of today, January 17th, is that there is no increased disease severity signal in children. Now, given the very high number of children who have been infected, particularly over the last month, we do unfortunately see more children who are coming to our emergency room, and some of them have to be admitted. However, I do think it's important to emphasize that we don't see a signal of increased morbidity, that these children are all of a sudden more sick from this variant than from previous variants. And what is another important distinction in children is that the hospitalizations we see right now are not necessarily lagging 2 weeks or 1 to 2 weeks like you see in adults. We are collecting the data right now, but it appears that parents bring their children to the emergency room within the first 24 to 72 hours of disease onset, which is different than in adults. And the emerging evidence, what leads to risk factors requiring hospitalizations, is that mostly children below the age of 5 years, actually mostly below the age of 2 years, are coming to the hospital. And the symptoms are fairly similar to what we see in respiratory viruses in children, with upper respiratory tract infection and what's called bronchiolitis, which is also part of the upper respiratory tract. We do very rarely see children with pneumonia.
Doctor, I hate to interrupt. We're just over 5 minutes, so if possible, seek to wrap up in a sentence or two.
Okay, so I think I will stop here. That was probably my most important message I wanted to give you. Let me maybe close with one thought. I think that the issue of school opening is understandably a very sensitive issue with many different perspectives. However, I do think that these various perspectives have become significantly more polarizing, mostly recently, than they need to be. I think we must be professional and respectful in our public discourse. And I do think that the current polarization only increases anxiety among everyone. I think at the end of the day, we are all committed to advocating for children and youth, but we are also obligated, in my mind, as adults to set a good example. Thank you very much for the opportunity to speak to you, and I'm happy to answer questions if there are any.
Thank you kindly. Let me open up the floor. Members of the board, could you indicate if you have questions? I see Councillor Fillion, Councillor Wong Tam, and let me see anybody on the mic who's joining by phone. Oh, I see you've joined by video, Trustee Donaldson. All right, Councillor Fillion, you'll have 5 minutes when you're ready. Any questions?
Thank you. No, I just have one, and thank you, Doctor, for that presentation. And I fully accept that the risk to children's social, educational, and emotional well-being is greater from school closings than to medically from getting the virus in all likelihood. But I guess my question has to do with the school children, like a different equation is the school children catching it at school and then bringing it home to more vulnerable people in their households, especially if they are living in 3-generation households.
Thank you very much for the question. I think you are absolutely right. And what I wasn't able to speak about is that one of the most important strategies has to continue, as you heard, the vaccination, not just of our children, but also the household members of where the children live in. I will say, if you look at the last 4 weeks, though, schools have been closed, and the significant number of children that have been infected were infected outside of school. So I do actually believe that with the significant infection prevention control measures we have in place here in Ontario, that schools present a much more structured environment for children than they have been exposed to within the last few weeks. So we have had lots of discussions around the science table because of the lack of modeling data around Omicron, but previous modeling data have shown that school closures are not one of the most powerful public health measures to reduce community transmission, meaning in another way around, I'm not sure that we are going to see a huge exponential increase to the case numbers that we have been seeing over the last few weeks in children.
Thank you very much.
Thank you, Councillor. Councillor Wong Tam.
Thank you very much, Doctor, and thank you for taking the time to speak to the Board of Health today. We thank you for all the work that you're doing and everyone who's working in the hospital sector. I have a question regarding the clinic that I believe Sick Kids opened specifically to deal with heart inflammations or myocarditis at Sick Kids Hospital. Is it true that you folks opened a clinic last summer, or is it this summer? I'm not sure.
That's correct. We are following all the children who have myocarditis either as part of the multi-system inflammatory syndrome that develops usually several weeks after you had a COVID infection. We have also seen very, very small numbers of children who develop pericarditis or myocarditis after the vaccine, and we are following these children. All of these children are doing well, but you're right, we do have a clinic where we are planning to follow these children at least over the course of 1 to 2 years in order to see whether they continue to remain stable and whether there are any other impacts we would see.
Thank you, Doctor. And I'm just curious, the chest pains, if there are any, how do parents determine whether or not they need to bring their child to to your hospital? Because we hear about what you just said about the normal upper respiratory infections that children get. I know my toddler seems to always be sick. And how do we distinguish, when to bring a child in? Or is this, maybe you can explain that to me.
So the symptoms that parents described when children complain about chest pain, and that's really in mostly children about the age of 12, where this is the majority of the case, are very distinct from any symptom that you generally are used to when your child has a cold or the flu or any other symptoms. So I will say that we have seen very, very few parents bringing their child to the emergency room with chest pain that didn't turn out to be causative or associated with something. So it's a very distinct pain when children come to you and say, my chest hurts, because that's something you don't hear very often. And that's when we see these parents either in our emergency room or what we hear from our colleagues in the community.
Thank you. And just out of curiosity, is the clinic expected to stay open for, you said you're going to track the kids for a couple of years. Have you ever opened such a clinic before? And how long do you intend to keep this clinic open?
So I will say that we are opening based on various different needs, new clinics for new symptoms or new diseases, all the time. I think we will try to keep this clinic open for as long as we feel it provides benefit to the patients as well as benefits to the scientific community, right? We are collecting a lot of data on these children that will help us inform to learn about a disease that honestly we have known only for 2.5 years. So I think we'll keep it at least for a couple of years, if not longer.
Okay, thank you, Doctor. And I want to just ask you a question regarding your comments about kids going back to school. And I think that this is obviously going to be an issue that is emotional for many people for a whole host of reasons, especially parents and those who are struggling to, and in particular students. You mentioned the fact that it could be more harmful to keep the students away from school, so away from in-class learning. But what would you say to the parents out there and the students out there who may be concerned that the schools are not necessarily safe enough, like quote unquote safe enough, depending on the parameters that you define, public health and safety? What assurance can you give to the parents and students that it's okay to send everyone back?
So like you said, this is obviously a very complex question, and I think I cannot tell you how many conversations I have with parents, either of my own patients or just within my social circle about this. Everything that we have been doing over the last 2 years, everything is based on a risk-benefit analysis. Now, this risk-benefit analysis looks very different for different individuals. And when I have parents call me about concerns, then I often tell them that in principle and in general, I think we have some very, very strict layers of infection prevention control measures in every school in Ontario. That's not to say, though, that sometimes for certain families, the risk-benefit analysis doesn't work the way of making a decision to send your child to school. And I think that's important for us to recognize. While I think we cannot make a decision for millions and millions of children to keep them out of schools for a prolonged period of time, there are certain scenarios. I just had 3 discussions with parents of my patients yesterday, 2 of whom decided they want to send their kids to school today, and 1 decided not to, and that's okay. I think that's important to recognize.
Thank you, Doctor.
Thank you, Councillor. And finally, I have Trustee Donaldson.
Thanks, through you, Chair. Thank you so much for coming this morning, Doctor, and for sharing this really important information with us. So I'm a school trustee at the Toronto District School Board, and the last couple of weeks, the school closures, things seem to have shifted. I'm especially interested in your comments about the impacts of social isolation and the decline in mental health for young people. And I think you said a tripling in clinically significant depression and anxiety. I'm now hearing from my community children as young as 8 and talking about the impacts of social isolation. So I'm wondering if you've observed anything in the last couple of weeks with this current school closure that concerns you. Thanks.
Thank you, Trustee, for the question. I'm going to be honest that what has concerned me most is that I have had 2 clinics with my patients, and over half of parents have asked me about how to set up learning pods with friends and children in a way that is at least as safe as school would be. And that has been a developing concern that I have not experienced in all the previous school closures. So I think that a lot of children are complaining, are disappointing. A lot of parents feel an unbelievable pressure because they have to go to work and now trying to scramble, don't necessarily have the kind of access to daycare, or the children are too old and don't want to go to these daycares that are offered for essential workers. And this is anecdotal, what I'm telling you here. This is just my personal experience. But since you asked me, that is probably one of the concerns, in addition to all the other things I've spoken to you about, that's why I said as part of my presentation to you, I do actually think that schools provide a much more structured, supported environment. I mean, I think what our schools and teachers have done is like one of these unsung heroes of this pandemic, how they have supported the children in person as well as online as best to their capacity. And I think you could see that in the reaction of the many parents of my patient population, as well as my colleagues, that children are much more frustrated this time over the last couple of weeks and have voiced it maybe more so than before.
Through the chair, sorry. Thank you so much for that. Again, I really appreciate you coming to speak with us this morning.
And thank you. And Dr. Khan, you have one further member of the board with questions. That's Director Mulligan. And Director, you're joining by phone. Thank you. I'm sorry for the technical challenges.
Hi, can you hear me?
We can hear you loud and clear. Thank you.
Dr. Cohn, thanks for being here. I have one question. There was a statement from Niagara Region Public Health that said they've detected transmission within schools throughout the pandemic. And that in the fall, their contact tracing found 25% of elementary age children who became infected with COVID acquired that infection in schools. And so they felt it's important to take increased safety measures in schools. Can you speak to that statistic and whether it correlates with your experience, what you're seeing at Sick Kids or what you're seeing across the province? And can you tell us what other safety measures you think would help improve not only safety about COVID transmission, but also people's sense of mental health and safety being in the school environment? Thanks so much.
Thank you. Yeah, so I am aware of the data from Niagara, and they are quite different than what we have seen within the Greater Toronto area, as well as in Ottawa. So the in-school transmission and the way how you determine this is by sequencing the genomic sequence of the different children and or school staff who have been infected, has not shown this high transmission in school that has been observed in Niagara. I do think we need to be very aware, though. These are all data that are for Alpha and Delta, for the Alpha and Delta variant. So we don't know what is going to happen with this massively more transmissible Omicron variant. I think as it relates to the safety measures, I mean, what we have been repeatedly mentioning are a couple of things. Most importantly is the concept of the layered measures of infection prevention and control. There's not one single measure that's going to make a school safer versus not so safe. So the combination of now increased mask quality like N95, K95 supply for teachers, plus the ongoing cohorting, plus available testing strategies that are really going to be critical in order to also keep schools open, but also in order to detect cases and manage those effectively, plus obviously vaccinations. If you take them all together and you really adhere to these rules the way how they are outlined, I do believe that you can minimize school transmission. There will be school cases, there will be school transmission. I mean, I'll make this clear that I am not talking about something that we won't see, but I think there are lots of measures in place that, if taken together and all worked for and applied for, will keep it hopefully as minimal as possible.
Thank you very much. Seeing no further questions, thank you for joining us, Doctor. And we will now proceed with other public deputations. Our next speaker is Dr. Doris Greenspan from the Retired Nurses Association of Ontario. Do we have Dr. Greenspan on the line?
The chair, this is the host. Dr. Greenspan is on the line, and I am unmuting them now.
Thank you.
Thank you, Chair Cressy. I must say it's not retired nurses. Maybe that was a hint. It's registered nurses.
Registered. Did I say retired?
but
registered.
I take it. And so thank you very much to you and to Dr. Davila and to the entire Toronto Board of Health, with whom RNO has quite a very strong relationship, as you know, as you guys are one of our best practice spotlight organizations. We provided a written deputation, so I do not want to focus on absolutely every point because Dr. Davila already presented much of the data. I do want to focus on two issues following on Dr. Cohen. One is on the issue of detentions. And I very much appreciate that comment because the tensions relate to this dichotomy that has been created, the Board of Health. It has been linked to the tension between in-person learning and online learning, as if some believe that forever it will be online learning and some believe that in-person is the good thing. Everybody in Ontario, I believe, every single person believes on in-person learning. Otherwise, we will all be doing homeschooling, which most Ontarians and Canadians don't. So there is no doubt in-person learning is the best. The question is, what's the right timing? That's really what we are focusing here. And here comes one of my online learnings ringing the doorbell. So I will need to open it. Not this will. Sorry about that. My apologies. So there is no doubt in-person learning is the preferred mode of teaching, but the issue is timing, and what RNO is recommending is that it not be during the peak of the rise of Omicron. That is really the issue that we are discussing. The second thing is the issue of kids don't get very sick. Well, thankfully, kids don't get very sick, and that is correct. But as you will see in our submission, kids transmit the Omicron, and in fact, more than adults, simply because they cannot be as strict with the issue of mask using. Most of them do not use KN95, etc., etc. So the transmission to the homes, and everybody has pointed to this, and it's the case, and especially to vulnerable homes, is much, much higher. And those, of course, also are the kids that are not vaccinated, right? So it coalesces that, again, those that we will see, both kids and adults in hospitals and in ICUs, will be from the most vulnerable population. I am yet to see, with all the tremendous work that the Toronto Board of Health and other boards have done, that we are reaching more than 50% one dose in the 5 to 11, and only even less than 10% with fully vaccinated. So we are hugely concerned. This at the time that the health human resources, in particular in nursing, that needs to attend to those kids and adults in hospitals and in ICUs is decreasing daily, as you know, because number one, illness, number two, they have their own family challenges, number three, exhaustion, etc., etc. You all know what the situation is. So the other piece that I want to raise is that we have been so far very fortunate with the flu season. I didn't hear Dr. Cohen mention that, so I want to touch on that. While we are being very, very lucky, we cannot count on luck, and hence why we are saying let's postpone for a week at least and reevaluate the issue of in-school learning, because south of the border, they're not as lucky, and the rates of flu are significantly higher than last year, less than the previous 4 years, but they're very high. And as Dr. Cohen knows, in Israel, there is a massive problem with the issue of children, false group, flu, and Omicron in the hospitals, and they're absolutely full. So same challenges. In fact, they gave to 7,000 doctors yesterday the order to go to work with symptoms. So we need to look at what's happening around the world. I think overall in Canada, we are doing relatively well. All we are asking is let's not blow it. Let's take the next week. This is a critical week. One day is already gone, so it's 4 days. Let's take the pulse and let's reassess on Friday, and then we all are on board pushing forward. Anyways, we will all push forward. There is no doubt about that. Every single nurse, every single doctor, every single one of you is doing that. We
just over 5 minutes, if you wouldn't mind wrapping up.
I am okay. I just want basically to say it's an issue of timing, not an issue of believing or not on in-person learning. We all do.
Thank you very much, Doctor. And as you said, the Registered Nurses Association of Ontario, not retired. Let me open it up to see if there are members of the board who have questions. If you do, could you raise your hand or unmute your mic to indicate so? And I know we have a couple members by phone as well. Councillor Wong-Tam.
Yes, thank you very much, Chair, and thank you for your deputation. I wanted to just ask if you can reflect upon what the previous speaker just spoke about, the need to sort of bring students back in. And I am hearing you that that you're asking us to slow it down, not necessarily do it so quickly, but I think there's an agreement, or maybe there's a slight disagreement as I'm gathering, is that the CEO of Sick Kids Hospital says bring the kids back, but you're saying do so, but wait.
Absolutely, absolutely, Councillor Wong. We 100%, there is not one single nurse in this province, unless they do homeschooling with their own kids, that will disagree with the fact that we need in-person learning for the social, for the emotional, for the academic, for the physical, for everything that we know schools exist. The issue only is when is best. And we are not yet at the peak of Omicron, and human resources are significantly low. We don't know if we are as lucky with the flu. We are saying this week, 1 day is gone. Let's pause these next 4 days and reevaluate on Friday. That's all we are saying, Councillor Wong.
Thank you. And I think we know that we don't have the same rate of vaccination in children at this moment, or student-age kids. And it may be some time before we get to having the majority of students vaccinated, including those who are under 5, which, as you know, are not eligible. If the week goes by and it seems that we're still kind of in the same situation as we are today, and we may still be in the same situation for weeks to come, what would your advice be for the Board of Health? Because I think we're going to get some conflicting information. I know this is a deeply complicated matter. And I know you don't have a crystal ball, so I appreciate if you can say, something that might just be your experience or what you're hearing from the nurses on the ground.
Yeah. So Councillor Wong Tam, first of all, let me tell you that RNO bases all the advice we do on evidence, nothing else. And the reality is we run the evidence-based practice not only for Ontario, but actually in Canada, and over 20 countries use our evidence-based guidelines, including the Toronto Board of Health on many areas related to clinical matters. Yes, you are correct. Only 49.7 children aged 5 to 12, I believe, is the last stats I have the vaccine dose, one dose, and then only 6.6 are fully vaccinated. So I say again, this week, these 4 days left, let's concentrate all the efforts in going to those vulnerable populations. It's very interesting when you look at the data. The grandparents, very much of them are vaccinated. The parents are, but both grandparents and parents say, but not my kid. So that's where we need to do education. We need to work with them. We need to come to the buildings of vulnerable populations. Look at the weather. Who can go anywhere to get the vaccination if you are in a vulnerable population? I believe that's where we need to focus our efforts. And I would suggest the issue of KN95, but we tried to convince the government of Ontario to provide to kids. That didn't work. But at the very least, let's step up the vaccination, let's pause, and let's reevaluate, I said on Friday, to see how are we doing with our hospital sector, what is happening in terms of human resources, so we don't end up with a collapsed system and without the care that people need.
Okay, thank you very much.
Thank you, Councillor. I have Director Mulligan.
Hi, Dr. Grinspan. Thanks so much for being here at the board with us today. I was wondering if you could speak to whether RNAO has any sense of what the health system impacts might be of returning to school earlier than you're suggesting. What do you think the impacts might be on nurses and on the healthcare system?
Yeah, I differ a bit on the opinion or the view, not opinion, of Dr. Cohen. I don't think we know exactly the impact, and that's where I put the precautionary principle rather than, let's hope, as he said, let's hope the impact is not too big. I don't think with this pandemic we can hope anymore anything, to tell you the truth. This Omicron virus has catch us really running fast, and I wouldn't go on any hope. I would go in the best we can based on the data we have, and that's why I keep saying, and on Friday we reevaluate. So I think the impact could be tremendous. If kids are ill, first of all, the parents may need to stay. That might be a nurse. If kids are ill, they bring the virus home, where, yeah, they may not become very ill, thankfully, but they transmit that to parents and grandparents, etc., etc., etc. I think we have seen what the overall impact is. We have seen that the impact in human resources, basically the system without reopening the schools, is almost about to collapse. The health system, as you all have seen from the media, and I hear daily till 2 a.m. from my colleagues. And the issue has been, it's not on the Toronto Public Health, because honestly, you all have done heroic work, but the province has moved sometimes, well, many times, too little, too slow, but also sometimes in illogical ways. Like if you think that we closed the schools for 2 weeks and we left much of the non-essential services open in different levels of capacity, well, that was not your problem, but the problem then it transmitted to everybody, right? Because that's what started really the path to health system collapse.
Thank you. We've heard, and I think rightly, a lot of important emphasis on the mental health and well-being of children and families right now. What can you tell us about the mental health and well-being of nurses? How are they doing?
Well, there is a mix of reasons why nurses are absolutely overstressed, and it starts with being overstretched. It starts with the fact that this, in the best case scenario, it is already a 2-year. If you think it's a 2-year pandemic that has required them to cancel vacations, et cetera, like many of us. But they work with workloads that are double and sometimes triple the usual. So that adds to the stress and to the burden. It also adds that sometimes they do go, whether it is to a manager in a hospital or whether it is to the family doctor, and they're told, no, even if you are overstretched and even if you want to take time off without pay, we cannot give it to you. That happens in a specific hospital. I addressed it with the CEO, and that happened yesterday and was all over tweet with a family doc that said to the nurse, sorry, I cannot give you the time off. You know, and while I understand from where they're coming, it doesn't work. Those two people quit on the spot, right? And like that, many others. And this is why it is absolutely critical that we understand that health human resources are stressed and stretched to the limit and exhausted. So we can't afford any more hiccups of things that the precautionary principle is kind of in our face saying to us, at least the way I am seeing it, and my colleagues, all of the nurses. Our deputation represents, I would say, 95% of the nurses and their views. It says, let's go baby steps to make sure we don't make another blunt and we end up in a much worse situation. And the weather helped us. It's only 4 days left now.
Thank you, Chair Cressy. I just have one more question. Dr. Grinspan, you mentioned measures at schools like ensuring kids have access to respirators like KN95. You mentioned measures outside schools like whether or not we're keeping non-essential services open. Are there other measures that you think that are really important to have in place right now so that we can ensure schools remain open safely?
Dr. Milligan, I think that we all know the recipe, right? Ventilation, both in schools and to educate people in their homes. Ventilation, the KN95 for kids, but they can't afford it. They're too expensive. And what is going to happen during lunch, for example, right? Even if kids wear the mask during the class. The issue of no singing and, no activities that even, we all know by now, and we should educate people that not only Omicron, but COVID-19 is airborne. I mean, it took for ages to say it, but it's airborne. It transmits like smoke. It's great that we are washing hands, keeping social distance, and cleaning every surface, but that's good for the flu and the cold. And I'm not diminishing the importance. Let's make sure we keep that habit on. But COVID-19 and Omicron is airborne, so anything that means air is where we need to put our attention. And then, of course, vaccination is absolutely the best tool to really not end up at least in a hospital or in an ICU. Absolutely. Full vaccination, though.
Thank you.
Thank you, Director. Are there any other questions from members of the board for Dr. Greenspan? Hey, thank you very much, Doctor. Our next speaker is Greg Nittel. Greg, do we have Greg on the line?
Yes, I'm here, Councillor Cressy.
Welcome. You'll have 5 minutes. Thank you. We can hear you loud and clear. You'll have 5 minutes and you can begin when you're ready. Thank you.
I addressed these comments particularly to my councillor, Mr. Paul Ainsley. Please see my website at F2SG, that's fox2samgeorge.substack.com, dated January the 16th for the extended version of this speech and for references. My comments are directed to appropriate metrics for public health. As of 0800 this morning, there was no staff report for this item. So these comments are primarily based on the background files for the December Board of Health meeting. The background files contained reported COVID-19 cases, ICU capacity, and various COVID-19 vaccination statistics. These metrics have not been well adapted to Omicron, as Dr. Davila indicated in her presentation this morning. From the 2021 November 22 background file for the December meeting, I quote, development of a full suite of indicators for public health will require considerable effort and should be undertaken in collaboration with the Ministry of Health. I strongly recommend that every member of the board take 28 minutes and 37 seconds to watch Chris Martinson's video, CDC, FDA, NIH, and Fauci doing more harm than good, dated 2021 November 30th, available on Odyssey. And the link, of course, is in my presentation at f2sg.substack.com. Chris discusses the purpose of a public health agency and how to measure its success. All-cause mortality. Chris Martinson and many others advocate measuring all-cause mortality because it is simple, powerful, and readily available. It is not subject to as broad an interpretation as COVID-19 hospitalization rates or cases. It will indicate whether TPH interventions overall are saving more people than they are killing. TPH needs to start analyzing all-cause mortality immediately to get back on track with its public health interventions. Also, all-cause morbidity. Neither Chris nor I can propose a single measure of morbidity with the same power and simplicity as deaths. In addition to consulting with the Ministry of Health to develop metrics, I suggest the board consult with the citizens of Toronto. After all, Toronto is a major medical research center. According to lawyer James Cooper, the Ontario Ministry of Health has complete data on the vaccine rollout, which they are using for vaccine passports, their death registries, and information on hospitalizations. All sorts of Toronto institutions participated in the study called Effectiveness of COVID-19 Vaccines Against Omicron or Delta Infection by corresponding author Jeff Kwong, dated 2021 December 30th. But I can't find any participation from Toronto Public Health. This study used Ontario vaccination and testing data. So appropriate data exists. Has TPH requested the provincial health data that applies to Toronto? Has TPH analyzed it all with respect to mortality? Does TPH have any analytic capability, or at least the ability to team up with any of the multiple research organizations in Toronto? And if not, is TPH willing to post the anonymized data so others can analyze it for you? I'll also comment very briefly on vitamin D, because vitamin D seems to me to be there's enormous evidence now that vitamin D levels correlate inversely with the severity of COVID-19. Not only that, but instead of negative side effects, vitamin D has broad positive effects against other diseases as well. What is not to like about vitamin D from a public health perspective? Where is the mass vitamin D level testing? Where is the lobbying to cover vitamin D testing under OHIP again? Why does TPH not champion vitamin D testing as a public health equity issue, especially since it affects people based on how dark their skin is? TPH has to start.
Speaker, you're just at 5 minutes. Could I ask you to wrap up in a sentence, please?
Sure. TPH has to start acting on vitamin D for me to take you seriously as a public health agency. Thank you.
Thank you kindly. Let me see if there are any members of the board with questions. Okay, seeing none, thank you very much, Greg. Our next speaker is Margot Boyd. Margot, you've been with us before. Welcome. You'll have 5 minutes and you can begin when you're ready. Do we have Margot on the line?
To the chair, this is the host. Margot is on the line. I just unmuted them, but it looks like they muted themselves. So Margot, I'm going to unmute you again.
Sorry about that. I thought I had to do it myself. Thank you, clerk.
We can hear you, Margaret. You'll have 5 minutes when you're ready. Welcome.
Thank you. If it's all right with the board, may I cede my position and go later because there's somebody who's been waiting for quite a while and he would like to speak. He needs to get back to his job. Is that okay?
Margot, we're also, I'm just conscious on the board members, we haven't received that request from the other individual. So if you'd like to speak, I would encourage you to.
So I can't cede my I can't switch places with Dan Hartman. Is that he's waiting on the side of the road in his truck and he's been waiting for quite a while. I've been informed. So I just said that I would offer up my spot and I would go at the end if it pleases the board.
Oh, you just hadn't indicated who it was, and we haven't received a request from them, so that's fine. Happy to make that work. So to Nahom from the clerk's office, if we could unmute Dan Hartman.
Yes, now unmuting Dan.
Dan, welcome. You'll have 5 minutes. Thank you for joining us, and you can begin when you're ready.
Hello, good morning. No deaths are being reported. You're talking about numbers and ICUs, but nobody ever talks about deaths. And it is happening more than anyone knows. And it's just being denied and silenced. And I have just don't think vaccines for kids to play sports is the right thing to do, considering Omicron is a lot less powerful. And I just want answers, and nobody will give me any. That's all I really wanted to say.
Thank you, Dan. And I'm glad we were able to accommodate the time here for you. Let me just open it up to members of the board. Are there anybody with any members with questions for Dan? Seeing none, Dan, I'm very sorry for your loss.
Sorry, Councillor.
Thank you for joining us.
Sorry, Councillor. It's Councillor
Sorry?
Wong-Tam. Sorry, Chair. It's Councillor Wong-Tam. Can you hear me?
Yeah,
Yes.
go ahead, Councillor. You have 5 minutes. Thank you.
Thank you very much. Mr. Hartman, I'm sure that on behalf of the Board of Health, I can express our deepest condolences to you and your family. I have a 2.5-year-old son. I can't imagine what it feels like to lose a child. So I'm sure our thoughts are with you. And thank you very much for taking the time to speak to us, because I also recognize that it can't be easy to do such a thing. I wanted to just ask, and you can tell me if it's too difficult to speak. Where does one go from there? What are your next steps? And I realize that you're looking for answers, and I'm not sure we can give you all those answers, but what do you plan to do next, if you don't mind sharing that with us?
I'm not sure. It's happening. It's on Twitter every day of people dying from this. I'm not an anti-vaxxer at all. Like I'm really not. But I think there's something wrong with this one. It wasn't even tested for 5 years. They just pushed it out there to the people.
Mr. Hartman, I have a quick follow-up question for you, and I don't know the process, but perhaps it may be helpful. Thank you very much, Mr. Hart. Thank you. I hope that you and your family are able to find some closure. Thank you.
Thank you.
Thank you, Councillor. Our next public speaker is Anne Nolan. Could we connect Anne on the line, please?
To the chair, one moment, please.
Thank you. Nahom, just checking on an update.
To the chair, it does not appear that that speaker is connected.
Okay, thank you. And I'll just check again. So Anne is no longer connected. Is that correct?
That is correct. We will keep an eye on the attendee list to see if they end up reconnecting.
All right, please inform me if they do. Our next speaker is Alice Kavanagh from Health Providers Against Poverty. Do we have Alice connected?
Alice is connected. I'm now unmuting their line.
Wonderful. Alice, welcome. Thank you for joining us. You'll have 5 minutes and you can begin when you're ready.
Thank you very much, and thank you for the opportunity to speak with you today. My name is Alice Kavanagh, and I'm here today on behalf of Health Providers Against Poverty, or HPAP. HPAP is an alliance of healthcare workers, including nurses, physicians, social workers, and other frontline health and social service workers, primarily based in Toronto, but also across Ontario and Canada. As healthcare providers, many of whom work in and around the Toronto shelter system, HPAP's membership is gravely concerned about the shape of the COVID-19 pandemic for people who are unhoused or precariously housed in our city. As we prepared this deputation, one of HPAP's members, a team member on a general internal medicine service in a busy downtown Toronto hospital, shared a story of spending many hours over the past several days last week trying to find safe shelter and shelter space for a patient who is ready to be discharged from hospital. This included being on hold with central intake for hours, just to be told to call back later or to call back the next day. When their patient was finally offered a place, it was at a shelter site that was well out of the downtown, away from this patient's healthcare support, and it was only available if that patient could arrive within the next 2 hours. Similar stories are coming from all corners of our membership and beyond. The transmissibility of the Omicron variant, together with the low vaccination rate amongst people experiencing homelessness, along with the high rates of complex medical comorbidities in this population, produce a high risk of high-risk infections, no matter where people who are unhoused are finding shelter right now. This risk is compounded in congregate shelter settings. These concerns have been borne out by the numbers that Dr. Davila shared earlier today. As of this past Friday, there were 50 outbreaks across Toronto's shelter system, which is more than half of all shelters in the city, and 401 COVID-19 cases in those outbreaks. On Friday, the city reported the death of one shelter resident, and we are aware of the deaths of many others through the pandemic, as the COVID-19 pandemic has collided with the enduring crisis of Toronto's toxic drug supply. We're aware of and applaud the recent announcement regarding the provision of 300,000 N95 masks to unhoused community members and the opening of 2 new emergency shelters, and we want to recognize that these are significant and important steps. However, we believe that these actions alone are not enough to protect our patients and clients who use the shelter system, who are trying to survive outside or who are precariously housed or facing evictions. On behalf of HPAP's membership, I wanted to urgently request the Board of Health's aid in obtaining additional assistance along the following lines. First, we do want to underscore again the importance of making sure that the PPE announced last week quickly makes its way to shelter and drop-in residents and staff. Similarly, resourcing vaccination efforts in these settings is vital. We also want to underscore the importance of increasing space for isolation and recovery. The opening of 2 emergency shelters announced on the 14th is an important step in securing more space for those experiencing homelessness, as overcrowding in the shelter and congregate and shelter spaces is an important modifiable risk factor that increases likelihood of infection with COVID-19. We also want to underscore that more shelter spaces are needed, particularly options for tiered levels of medical support and isolation for folks who are infected with COVID-19. Specifically in recognition that the Omicron variant has a wide range of symptoms and presentations. We know that some people are going to have COVID-19 and have no symptoms, and therefore are going to require spaces to isolate safely with, meals and harm reduction and social support. Are going to need more clinical support from healthcare professionals and require more intensively staffed recovery beds. So we really want to underscore that there's a need to increase both of these types of shelter spaces at present. We also want to recognize that as with all new shelter spaces open in this wave, as well as spaces already open, harm reduction support are really urgently necessary to go along with those shelter spaces. 20% of all overdose deaths in shelters occurred in shelter hotels in the last COVID-19 wave, according to the city's own data. We're also aware that PCR testing is a limited resource at present, but we want to note that shelter users are a high-risk population, and increasing access to rapid antigen testing and PCR testing for clients and staff are necessary to facilitate effective triage in these spaces. We know that our members who are working in frontline roles are currently also reporting that it's quite difficult to understand which shelters are in outbreak and how to access non-outbreak shelters for clients. So we really want to urge the importance of transparency here. And finally, we want to echo the call from the Shelter and Housing Justice Network in their winter plan for 2022, calling on opening additional warming centers, changing the requirement there from 15 to 20 degrees below zero with wind chill to 5 to 10 degrees below zero with wind chill. Thanks.
Thank you very much, Alice, and thank you for the patience with us getting to you. Let me just open it up to see if there are members of the board who have questions for you. I see Councillor Ainsley. Councillor, when you're ready.
Thank you. Ms. Kavanaugh, I guess in a nutshell, you're just saying you would like to see the medical officer of health work much closer with our shelter support system staff?
I think that we need to make sure that that the needs of folks who are living in shelters, who are accessing shelter space, and who are accessing these resources are brought to the forefront of the attention of the Board of Health and of the medical officer of health. Yes.
Okay, and could you just, I guess, elaborate, like if you had to pick the top 3 things that the medical officer of health could do to help our shelter staff, what do you think they would be?
The calls that HPAP is specifically bringing forward are about really realizing and making sure that the PPE that was announced last week makes its way to shelter residents and staff urgently, as well as making sure that we have options for, we have non-congregate shelter spaces that are available for folks, because we know how dangerous congregate settings are given the nature and transmissibility of Omicron. And then finally, making sure that we have really tiered levels of support for folks who do contract COVID-19. Some folks are going to need a lot of support by virtue of the types of medical issues that they are experiencing. And also making sure that we have a harm reduction support available to everybody who is in Toronto shelters right now, because we know that the overdose crisis and the pandemic are really twinned and intertwined challenges at this point.
Okay, all right. Thank you very much. Those are my questions, Chair Cressy.
Thank you, Councillor. Let me just see, are there any other members? Okay, we're going to go to our next speaker, and just a time check for members of the board. It's 12:15. At 12:30, we will break for a 30-minute, a condensed 30-minute recess before returning at 1. Our next speaker is Kathy Crow. Kathy, do we have you on the line?
To the chair, that speaker is connected. I'm now unmuting their mic.
Oh, welcome, Kathy. Thank you for joining us. Kathy, you'll have 5 minutes. And please begin whenever you're ready.
Thank you. I have to start with a snow anecdote. On January 17, 1999, yes, the Army was called into Toronto, but it was also in part because the Board of Health was meeting and there were many homeless deputants there that day calling for more shelter, and the armory was open, the federal armory. So here we are again today. Being able to stay home and say you have one is probably the most important Canadian social value next to our love of Medicare. This has never been truer than in a pandemic. It's why I argue that our city, but also the Board of Health, must advocate for a federal emergency rent supplement program in the thousands to be able to transition people from shelters and from the street and encampments into safe housing while we wait for social housing. Being able to protect yourself from COVID infection should not be dependent on your postal code, your income, or your ability to purchase good mass or rapid tests. That applies also for people who are sick with COVID. So I want to focus today specifically on the city's strategy to isolate most homeless people in situ, in shelters, in respites, shelters, hotels, unless they somehow magically can get into the very full recovery hotel site. The city SSHA sent me correspondence that said, health and public health experts have stated that it is no longer possible or advisable to try to move all clients who may have been exposed to COVID-19. This decision is being equated by doctors, nurses, and shelter workers to, quote, letting COVID rip through the shelter system. And the numbers speak for themselves. December 31st, 16 shelters were in outbreak. On Friday, 50, with 401 people infected in those outbreaks. The decision to downsize the recovery hotel, the isolation program where homeless people were cared for 24/7 by health professionals, from 160 rooms to 60 was ill-advised in an unpredictable pandemic. The reality of the isolation in situ model is perhaps unimaginable to you. Despite protocols, there are poor infection control practices, inconsistent indoor masking, screening, and testing. In fact, there's a video online this morning from a homeless person showing workers entering his room not wearing N95s. We thank you now for providing N95s to shelter clients. That was a very positive step. Worst case in situ isolation scenarios include an infected person kept at one edge of a large gymnasium type space. Shelters that purport to be able to isolate, in fact, cannot. Imagine being ill with muscle aches, fever, coughs, shortness of breath, sore throat, headache, chest pain, vomiting, diarrhea, and on top of that, you were in a room with many other people, or not in a bed even. You might be in a cot. No friends or family to care for you, no healthcare staff. A young woman told Ben Cohen of the Toronto Star, "After my boyfriend and I were put in isolation, nobody came to check on us for 18 hours. I had to use a plastic bag to urinate in. Nobody came. I didn't get a drink of water until the next day." Now imagine if you're COVID positive but staying with many people around you who have COVID in an indoor space with an airborne virus. It's a public health disaster. The SSHA correspondence I received had an encouraging line in it. It said the city is working with health partners to explore options to increase dedicated isolation and recovery. So it is imperative that the Board of Health call for expanded isolation recovery space urgently. I like to use the word infirmary. I think it's more understandable. You need to pivot. The ideal would be reestablishing full capacity at the recovery hotel program. Other options could include requesting federal provincial provision of field hospitals, repurposing one of the sprung domes now used as respite shelters, utilizing another public buildings such as the Better Living Center, or expanding the infirmary medical unit at Seton House. But I want to stress that there's no time for this to go to committee or go to council. These are decisions and directions that I'm hoping that the Public Health Board, that you will support and that staff will enact. Thank you.
Thank you very much, Kathy. Let me open it up. Members of the board, Councillor Ainsley.
Thank you, Chair Cressy. To the Deputy, Kathy, I wanted to ask earlier in your comments, you talked about, I think it was the hotel recovery sites, and you used the word magical. I think you said magically, if they can get into a hotel recovery site. Could you, explain that a bit?
Certainly. Thanks, Councillor, for the question. So the recovery site, the hotel program has been downsized from approximately 160 rooms to 60. Other floors in that building are being used as regular shelter now. So because of obviously the huge numbers of people who are now infected with COVID in the shelter system, not everybody can get in. And although there's sometimes 1 or 2 spaces available, it's very, very hard for people to get in or to be referred in because it's only 60 spots. We have 50 shelters in outbreak as of Friday. Today, the number will probably be 5 or 10 higher, and the numbers will increase. And this includes families with children. This includes seniors. Reading the names of the shelters is quite shocking when you read. Some of the shelters are seniors shelters, and it means that workers there cannot refer everybody who needs isolation in. And I guess I want to stress that infirmary aspect, that care aspect that can't be provided by shelter workers are not health workers, although they certainly do a lot of health care.
Okay, and then Kathy, I guess you made a comment about healthcare, and you mentioned that there was one person that was diagnosed with COVID, and they were put at one end of a gymnasium, and you talked about another person who had a room check done, and the person were wearing, the kind of standard medical mask and not an N95 mask. So when it comes to healthcare in the shelters, I guess, for example, masks, you know, we're hoping students will be provided with N95 masks, and they're getting test kits, rapid test kits, and home with them. So you would look for that same level of care for people in our shelters as well, is my understanding.
Yeah, definitely. I think it's important to note that most shelters do not have healthcare on site during the pandemic. Seton House is an exception, and other healthcare providers may still be going in, but they're not there during the pandemic 24/7. And I mean, very early on in the pandemic, I tried to urge the city to make sure that there was a nurse or an RPN at every shelter to be a liaison. Shelter workers are overloaded to begin with. And I think they need the support and the reminders and the teachings of why it's important to wear an N95, why it's important to isolate, and what are the symptoms that you look for in a person who might be infected, who might not be able themselves to tell you that I think I have a fever or I have this symptom. So I think we're missing and we're leaving people very vulnerable by expecting them to isolate in situ. And I urge each of you, think about your own experience. If you've had COVID or know somebody that has, people become quite sick. And if you're isolating in a shelter, you don't have a medicine cupboard, you don't have ibuprofen, you don't have that extra apple juice or somebody to make you scrambled eggs, you know, once your appetite comes back. And that is what could be provided in an isolation site with 24/7 staff. I'll also just add that the Recovery Hotel program is one of the gems of what the city did in response to COVID in the homeless population. Wasn't perfect, but I've always raved about it, the model, and downsizing it to 60, and when knowing, you know, it was a serious error. And I would urge staff that are considering this issue to support ICHA, the Inner City Health Associates, and the other partners that staff that facility. Thank you.
Okay, excellent. Thank you, Kathy. I really appreciate your input and your suggestions and your insights this morning. Councillor Chair Cressy, those are my questions. Thank you.
So Councillor Cressy's screen is frozen. He has just, or his connection has frozen. He has reached out to me by text just to say that it's probably an appropriate time to break for lunch. I did see some more hands up, so I'm hopeful that that Kathy can stick around until after the break to answer any questions there. Could I see, is there only, Councillor Wong Tam, is it only you with your hand up? Anyone else? Maybe we let Councillor Wong Tam ask questions. I hate to backseat chair here, but just to help move things along, and then we'll break for lunch after that. Councillor Wong Tam?
Sure, Councillor Lane, and hopefully Councillor Cressy can get back on the call shortly. Kathy, thank you for your time today, for your deputation. I want to just quickly ask you with respect to the capacity of ICHA. Obviously, they were staffing the 160-bed recovery site. It's now been moved down to 60. Based on your conversations, I know you have some very close contacts there. Is there any challenge in having ICHA scale back up to 160 as far as you know?
Well, there could well be, for sure. I know that many, I shouldn't speak on behalf of ICHA, but it's my understanding that many of their nurses are doing vaccinations right now. And I anticipate that won't be, the need for that will not necessarily go on forever. I think ICHA is a very successful organization, and I think they could be consulting with Doctors Without Borders and bringing in other volunteers or hiring more RPNs or PSWs, for example. So, I mean, it's a challenge everywhere, the staffing sector, but that doesn't mean you don't try.
Thank you very much. And with respect to your suggestions about creating alternative isolation infirmary-style beds, you mentioned, I believe, perhaps some community centers. Did you say that as well? Your audio cut out a little bit for me, so I just want to make sure I captured all your recommendations. So
yes, I might not have said it, but it's in my deputation for sure. Yeah, I mean, I just think we have to think out of the box and look at, I mean, obviously I would prefer one room per person, such as the Recovery Hotel. And I would prefer that, but I think we have to look at other models. And at one point, Doctors Without Borders was consulting with the city or with each looking at a congregate site recovery program. I just think we have to look at different models and do what we can. Certainly staffing might be different depending on the model. Yeah.
Thank you, Kathy. And then you touched upon Seton House, and I know I'm going to run out of time shortly, but Seton House is one of the only shelters in the city that actually has a medical facility on site and trained medical staff. Is your suggestion that we expand the medical side, the infirmary side of Seton House, and take those numbers by sort of offsetting the general population? Because there's only a finite amount of space there. I just want to understand your recommendation.
Well, I just think it's a possibility to look at. They've got an entire floor converted now to, that's my understanding, to COVID positive because they had 36 cases on Friday. So certainly that's a possibility. You know, I have to say, like, I think it's good advice for the future of the shelter system. When I was in nursing school, we had an infirmary. So if we got sick, we went to an infirmary. And Sue Wong's nodding her head, I see. So, I mean, I think it is a model that is very, very helpful. This, you know, imagine being sick in a shelter and imagine being sick with COVID. It's just, it's not right.
Okay, thank you very much, Kathy.
Thanks, Kristen.
Thank you very much. Kathy, are there any other questions for Kathy after lunch or no? I don't see any hands going up. I see Gord nodding his head. So if Kathy, if you could come back, it sounds like you may have questions. We're going to be breaking until 1 o'clock, folks. That's what the chair has told me to inform you. So we'll see you back here at 1 p.m. Go and enjoy your lunch. Thank you.
Thank you.
Meeting is in recess.
We'll have 5 minutes. You can begin when you're ready. Thank you, Anne.
Okay, thank you. Hi, my name is Ann Nolan. I'm from Belleville. I'm speaking on behalf of my daughter, Haley Middleton. Back in September, the health unit of Belleville asked if Haley was getting her vaccines. I said no. And they said, okay, they hung up the phone. In October 6th, my daughter got her first vaccine. She's had 2 seizures and convulsions ever since. She's very sick. She wasn't before. She is now. And I believe it's all because of the vaccine. The school and the health unit both coerced my daughter to get this vaccine. They said that in order for her to join any sporting events or anything at school, she had to get it done. She didn't want to, but she wanted to join sports, so she had to. Hello?
We can hear you, Anne.
Okay. So I called her doctor and I told her doctor that she was getting convulsions, and they told me to take a video of it when she has that, take it to the hospital to see what's wrong. That's my story.
Thank you very much, Anne, and thank you for joining. Are there members of the board who have questions for Anne? Okay, seeing none, thank you, Anne. Our next public speaker is Dr. Roshan Killian. Do we have Dr. Roshan Killian on the line?
To the chair, this is the host. I do not see that speaker connected.
Okay, please let me know if they return. Our next speaker is Kelly Brown. Do we have Kelly on the line?
Kelly Brown is connected. I'm now unmuting their line.
Thank you. Kelly, welcome to the Board of Health. You'll have 5 minutes and you can begin when you're ready.
Thanks very much. Chair Cressy, members of the Board of Health and City Councilors, Medical Officer of Health Dr. Davila, members of the media, fellow attendees. Thank you for the opportunity to speak with you again. First, an impromptu comment. I'll just mention it's great to see on the city's COVID-19 dashboard presented by Dr. Davila that ICU utilization is at just 74% with a green indicator, an encouraging reading for the peak of respiratory season. I'll start with a brief update regarding post-vaccine myocarditis incidents in Ontario, and then address the slowing booster and 5 to 11-year-old vaccination administration. Last addressing this board on October 25th, 2021, I indicated Ontario had reported 455 known cases of myocarditis, approximately half of which occurred in young men aged 12 to 29. Since then, known reported cases have grown 36% to 618, an increase of 163 cases. A number of these would have no doubt occurred in the Toronto Public Health Unit, over which, of course, you preside. There remain approximately 300,000 unvaccinated young males aged 12 to 29 in Ontario. Based on known rates observed to date, if Ontario, including Toronto, vaccinate these 300,000 individuals, you will have knowingly sanctioned approximately 30 more cases of myocarditis-related bodily harm in young boys and men province-wide, with little associated benefit. You will have also sanctioned this with knowledge of a powerful new peer-reviewed study published since I last addressed this board, assuming Dr. Davila has shared it with you. This study from the UK, involving more than 40 million patients, published in the internationally respected Nature Medicine Journal and shared widely online, establishes that the risk of post-vaccine myocarditis exceeds the risk of COVID-19 related myocarditis in men under age 40. If Dr. Davila, dubbed the People's Doctor, has not shared this with you, that is a dereliction of her duty, which you ought to find disconcerting. Moving on, and regarding the slowing vaccine campaigns. First, regarding third doses. On Saturday, Chair Cressy tweeted that Toronto had reached a 70% third dose rate for ages 70 and up. The provincial number is similar. However, he did not mention that the third dose pace is much slower than the second dose pace was in summer 2021, when this 70% milestone was reached in just about 30 days. It took more than twice that long, approximately 63 days, to reach the 70% milestone for third doses, and the pace continues to slow. Second, regarding 5 to 11-year-olds. Provincially, approximately 50% of these children have received one dose. That took 54 days, and the pace is now slowed. Compare that to the just 28 days for ages 12 to 17 to reach that 50% milestone. In short, Ontarians and Torontonians, by the numbers, are not embracing third doses or child doses of the new vaccines as quickly as they have in the past. What could this slowdown be signaling? The myopic view held by all levels of government and public health continues to be that hesitancy can only be due to lack of education or access, or that now rather tired line, misinformation from the anti-vaxxers. But I believe otherwise. I believe it is clear this slowdown is signaling that Torontonians and Ontarians, and even the media, are now doing their homework. And in so doing, perhaps many are discovering and questioning the ever-waning protection from vaccines. Perhaps it is comments like the following by the Pfizer CEO, who this month said, quote, "I think the most likely scenario will be annual revaccination. I think that will be for years to come," unquote, that are causing them to ask whether years of new mRNA products are good for their bodies, or whether they want to sign up for the growing prospect of a never-ending annual vaccine QR code treadmill. For parents of young children, perhaps they've become aware of the issues young males and others have had with myocarditis following vaccination, and have observed your attempts to downplay and minimize these risks and to overstate the vaccine's benefits in these ages. Having done their homework, or having simply chosen caution, parents of children 5 to 11 years old don't need more education about vaccines. They need you to respect their increasingly informed decisions. In closing, there can be no doubt that public health awareness of the lack of homework performed and independent thought exercised by this board and all boards of health across this province will continue to grow. And with it, your continuing loss of trust of wider portions of the population. Thank you.
Thank you very much. Let me see if there's any questions from members of the deeply trusted board. Seeing none, thank you very much. Our next speaker is Margot Boyd. Margot, do we have you on the line?
Hello.
To
Hi.
the chair.
Yes, Nahom, go ahead. Sorry.
Sorry, I was just going to indicate that the speaker is connected and unmuted, but they are ready to go.
And welcome, Margot, and glad we were able to make that switch work with Dan earlier. So thank you for being here, and you'll have 5 minutes when you're ready.
Thank you. My name is Margot Boyd. I have a postgraduate degree in health sciences from what is now known as the Dalla Lana School of Public Health at U of T, where I was taught the imperative that policy be data-driven and evidence-based. I then interned at the Ministry of Health and subsequently worked at 3 different hospitals on University Avenue. I now work in the area of ethical advocacy. My children have their childhood vaccines, and in fact, one just had a booster for tetanus, just in case you wish to label me an anti-vaxxer. In the face of inaccurate and hate-mongering rhetoric being constantly pushed at us from mainstream media outlets against people who haven't taken the requisite number of mRNA injections, there are things to actually be happy about in the latest COVID-19 Omicron statistics. This past Friday, the 14th, there were 489, or 21%, unoccupied ICU beds in Ontario. COVID-identified patients are only 22% of occupied beds during our high respiratory infection season. It has also come to light that there is a high number of incidental cases of COVID included in the statistics, where people are admitted to hospital for another reason, yet are counted COVID cases due to hospital testing protocols. This practice causes an artificial inflation of COVID hospitalizations. Last Friday's ICU occupancy in Ontario for the unvaccinated was only 7%, counter to Star's Wendy Malick's weekend statement that the unvaxxed are blowing up the healthcare system. The vaxxed with 1, 2, or 3 doses and unidentified dose combinations accounted for 15% of ICU occupancy, over double the occupancy rate of the unvaxxed. Yes, that's over double the occupancy of the unvaxxed, according to Ontario COVID data. In addition to the issues with hospitalization data, we are now seeing flaws in what have been counted as COVID deaths. In a statement from the National Center for Health Statistics in the United States, which broke into detail the death certificates for COVID-19, they stated, and I quote, 94% of people who had COVID-19 also had other conditions listed. COVID-19 alone was the cause of death for 6%. End of quote. It has been revealed that those afflicted by other illnesses and conditions such as obesity and multiple comorbidities disproportionately affect the statistical picture for people who are otherwise healthy. CDC Director Rochelle Walensky also recently stated that most of those who have died in the past from COVID-19 have over 4 comorbidities, and that we need to learn to live with the new Omicron variant. We also know that mRNA injections do not confer immunity nor stop transmission, as they were advertised to do. On January the 10th, even the CEO of Pfizer admitted, and I quote, 2 doses of the vaccine offers very little protection, if any, end of quote. The booster adds a limited immune system boost, which fades very quickly, as the alpha spike protein injection does not protect against Omicron. Fortunately, that doesn't matter, as the Omicron cold is a game changer. There is encouraging data which shows that Omicron has the same case fatality rate as a cold at approximately 0.03%. Some of you might know that this is even less than the flu, which has a case fatality rate of 0.1 to 0.2%. You must be made acutely aware that the mRNA injections created for COVID contain the old alpha spike protein, which is the toxic spike protein associated with side effects such as myocarditis. Omicron, and this is very important, has no such toxic spike protein. We see that the spike protein has been deactivated and can no longer hurt human tissues. Therefore, we must cease immediately in the use of this outdated mRNA injection in our naturally immune and resilient children and youth. There is zero rationale and a certain criminality behind further subjecting their young hearts to myocarditis. Illogical mandates pushed by public health on healthy kids to attend school and participate in sports have also drastically hurt our healthcare sector. For instance, we have cut staffed ICU beds by 1/3 over the past year and a half. Some hospitals have suffered such deep cuts that they are now forced to bring COVID-positive staff back into the hospital, which will only serve to infect the hospital population. We also see drastic cuts having taken place in the city's own emergency services. Why choose to fire naturally immune employees and subsequently blame the hospitals for the results of your bad policy? And why don't you release the precise number of emergency services workers that you actually fired? To continue to promote mandates that shoot ourselves in the foot is nonsensical. It's time for you to pivot according to what the evidence is telling us. The longer you take...
Say, Margot, you're over 5 minutes. If you could wrap up in a sentence, please.
I just have one sentence left. The longer you take, the bigger the apology that you will have to make. Thank you.
Thank you kindly. Let me see if there are any questions for you from members of the board. Okay, seeing none, thank you, Margot. Next, I have Donald Welsh. Do I have Donald on the line?
The chair, that speaker is connected. I'm now unmuting their mic.
Donald, you've been here before. Welcome back. You'll have 5 minutes and can begin when you're ready.
Okay, thank you, Councillor Cressy. My name is Dr. Donald Welsh. I'm a professor of physiology at Western University, and I have a specialization in cardiovascular biology. I'd like to take just a small portion of your time today to provide broader context on the return of children at a time to school, at a time when respiratory viruses are present seasonally. So as most of you are well aware, there are many seasonal respiratory viruses in circulation that medicine actively manages. Viral infection happens 24/7, 365. Most of the time you barely notice because your lungs' innate mucosal immune system destroys the virus very quickly. And this is especially true in children. COVID is a respiratory viral disease that is of little risk to healthy adults and negligible risk to children. This means that children hospitalization is rare, except those with significant comorbidities, and symptoms are most often mild. COVID is the highly age and risk stratified disease. And this is a fancy way of saying that those of advanced years and with multiple medical conditions are markedly more susceptible to bad outcomes, about 1,000 times more. And it's unfortunate, I should say, that this fact has not been better communicated, as it has consequences. What it does is it tends to amplify fear in low-risk populations while muting concern in higher-risk populations. So keeping this overriding perspective in mind, I just want to work through in a stepwise fashion some concerns and data that supports the return of children to school. First of all, Canadian and international data notes that children are of exceedingly low risk of serious outcome. And this is especially true with the Omicron variant, which has become dominant in Ontario over the last few weeks. While this variant has high transmissibility, it retains low virulence, about 1/4 of the original Wuhan strain. And it seems to preferentially lodge in the upper airways, so that's your nose and your throat. And it doesn't sort of locate in vital lung tissue. Now, this follows the standard evolution of coronaviruses, and at a ground level, this is good news. We are dealing with a virus that is akin to a cold or a mild flu, to which society has plenty of experience dealing with. Now, point number 2, large international studies have confirmed that schools aren't a significant source of viral transmission, particularly to the surrounding community. Nordic countries have known this in practice from the beginning, and it's why their schools have maintained near full functionality for 2 years. Ontario has been cautious to acknowledge this fact, the consequence being that we are near last in opening our schools. This has been a notable shortfall in our response, and one with economic and social repercussions that will spread well into the future. Third point, vaccination is not essential for the return of children. We have to be honest in saying the current mRNA vaccines won't confer a sustained community benefit. That means they don't affect viral transmission. And they have a very limited individual benefit for children because they're at almost near zero risk to begin with. I focused the preceding statement in regards to the Omicron variant, which is heavily mutated relative to the original Wuhan strain. Many of these mutations are found in the region of the spike protein targeted by the vaccinal process. So again, at a ground level, this means that Omicron can and will evade, although not fully, the vaccinal immunization process. So in a nutshell, the problem here is we're using yesterday's vaccine to address today's distinctive variant. Well, this knowledge may on the surface seem disappointing. We should recognize that biology treats the circulation of low virulence coronaviruses as a positive, as it builds robust co-immunity. This is a process whereby immune responses generated by viral infection is used to fight off similar viral infections. It's a remarkable evolutionary process known for decades, and it's evident in the Canadian population to counter CoV-2, and we've known this for a year. So the final point is, while I understand the innate human desire to control risk, we must keep in mind that there's little evidence supporting the efficacy of non-pharmacological interventions. Masking, social distancing, cohorting, and so forth are all theoretical ideas. Real-world randomized controlled trials are either absent.
Donald, you're just at 5 minutes. If you could finish in a sentence, please.
Okay, so I'll just say the one notable exception is indoor ventilation. So in closing, I think it's time for Ontario to look at the wealth of scientific and public health information, push forward for the full return of children to school. Thank you very much for your time.
Thank you, Donald. Let me open it up to see if there are any members of the board with questions. Seeing none, thank you. Our next speaker is Derek Morin. Do we have Derek on the line?
The chair, one moment, please.
Thank you.
I believe Derek Moran is connected by phone. I believe this is his number. Derek, I'm now unmuting your line.
Hi, can you guys hear me?
Derek, we can. Welcome. You've been here before, so welcome back. You'll have 5 minutes and you can begin when you're ready.
I'm just going to start my clock here. I just want to say by me speaking at this meeting, this shall not be deemed to be in any way my consent expressed or implied. In doing so as fraud, God bless Her Majesty the Queen and long live Her Majesty the Queen. And I have an objection to make to something you said at the end of Kelly Brown's presentation, Councillor Cressy. So let the record show that I do not trust the Toronto Board of Health. So that was pretty rough listening to Dan Hartman tell what happened to his son right after taking a COVID vaccine. And seeing that he's looking for answers, I'd point him to an article from Bright Light News I have in my written presentation titled, COVID vaccines are literally weakening the immune system, where pathologist Dr. Ryan Cole, MD, explains that COVID vaccines are causing a drop in killer CD8 T cells, which keep other viruses in check. Dr. Cole runs the largest independent lab in Idaho and is seeing a huge uptick in viruses like herpes, HPV, and shingles. More alarmingly, Dr. Cole has seen a sharp rise in cancers. And I believe in the article, Dr. Cole goes on to say that the spike protein used in these vaccines is actually a toxin. And by the way, when Councillor Wong Tam filled in for you, Chair Cressy, a few months ago, she expressed the need for better, more detailed data regarding COVID that would provide more context to the public. After hearing Dan Hartman speak about the death of his son right after taking a vaccine so he could play hockey, which the autopsy listed as the cause of death as unascertained, I mean, how many times has that happened? It occurred to me that one piece of data I believe I've never heard from Dr. Davila update the public on is how many people have died from the COVID vaccine. Obviously, after listening to what Dan Hartman had to say about his son, what happened to his son, I'm sure this board going forward is going to make sure from now on that Dr. Davila keeps track of and provides the data to us, the public, on just how many people have died from taking a COVID vaccine. And if it's any consolation to Councillor Wong-Tam, in my written presentation, I have a YouTube link to CNN's Wolf Blitzer interviewing the CDC's Rochelle Walensky, who said that our vaccines are working exceptionally well, but what they can't do anymore is prevent transmission. And this was posted back in August, around the same time Dr. Moore's memo came out that Councillor Wong-Tam took so much grief over for merely pointing out, and a shame really that she ever felt pressured not to seek continuing as the vice chair for simply mentioning the truth, though it went against the COVID narrative. In my written presentation, I also have a screenshot from the province's own data from their COVID page. It shows COVID-19 cases by vaccination status. If you look at it, what you will see is that per 100,000 people, there are 53.91 cases of COVID in those who are unvaccinated. However, the rate per 100,000 people as of yesterday, there are 67.9 cases of COVID in those who are fully vaccinated. That's a difference of 14 more cases in the fully vaccinated. If you work that out, that's a 26% difference. It's pretty unbelievable to think that compared to those who are unvaccinated, you have a 26% greater chance that you will get COVID if you are actually fully vaccinated. Remember that next time somebody tries to tell you these COVID vaccines are safe, and especially in this case, effective. But this data does make sense, however, in a way, considering that Ben Cohen of the Toronto Star recently quoted the Science Table's Dr. Peter Uni that people need to understand now that after 2 COVID vaccine doses, their protection against infection is next to 0. More evidence that these vaccines do not work is in a YouTube link I provide where recently Pfizer CEO Albert Bourla freely admitted that in an interview, 2 doses of the vaccine offers very limited protection, if any. This contrasts with a tweet he put out on April 1st, 2021, where he said, excited to share that updated analysis from our phase 3 study with BioNTech also showed that our COVID-19 vaccine was 100% effective in preventing COVID. 100%
Derek, you're just over 5
exclamation
minutes.
point,
Ask
he
if
added.
you could wrap up in a sentence, please.
Yeah, so I just wanted to point out that he sent this tweet out on April 1st. So I guess he meant it as an April Fool's Day joke that the Pfizer vaccine actually prevents COVID. And that's my time.
Thank you very much, Derek. Let me open it up to see if there are any questions for you from members of the board. Seeing none, thank you. We have 2 more speakers who registered this morning. Our next is Laura McDonald from Regent Park, CHC. Do we have Laura on the line?
To the chair, we do. I'm now unmuting their line.
Board. I actually had submitted a written deputation yesterday, but because of the fact of the vaccine clinic that I was staffing today being canceled, was able to come to present in person. I'm going to be really brief because I think many of the points that I wanted to underline were pretty well spoken to by Kathy Crow and by Alice Kavanaugh, but just wanted to underscore the need to maintain non-congregate shelter spaces at this time, and also ongoing. The isolation and recovery beds in the shelter system have, I think, been really important in mitigating the harmful effects of the COVID-19 pandemic on our most vulnerable folks. And I think we've learned a lot of lessons there as to what we can kind of do differently when a health crisis is really deemed urgent. So yeah, hoping that I can reiterate and express support for maintaining that style of wraparound, whether we call it infirmary bed or isolation and recovery space. And then also I would emphasize a little bit more, I think, than perhaps some others, the importance of the non-congregate beds in general, with or without medical supports. We just know in the shelter system in the last number of years, the patients who I work with and community members who I know, so many people are forced into using 24-hour emergency respite spots as shelter. And the conditions in those spaces, while, you know, being really necessary that they're there, are also, we know, contribute to some really bad health outcomes for many. So I think going forward, whatever we can do to maintain some more non-congregate bed spaces and really expand the capacity of the shelter system will be important, not just in moving past COVID, but also going forward. And that's all I have to say. Thank you.
Thank you very much, Lauren. I'm glad you were able to be here today. Though sorry, the clinic is not operating on account of the weather. Let me open it up to see if there are any questions for you from members of the board. Seeing none, our next speaker is, and thank you, our next speaker is Greg Cook. Do we have Greg on the line?
The chair, Greg, is connected. I'm now unmuting their line.
Greg, welcome to the board. Thank you for joining us today. You'll have 5 minutes and you can begin when you're ready.
Okay, thank you. Hi, my name is Greg Cook. I'm an outreach worker at Sanctuary. I volunteer for the Toronto Homeless Memorial, and I'm on the steering committee for the Shelter and Housing Justice Network. Today, I'm speaking on behalf of the Shelter and Housing Justice Network. The shelter system is in crisis. The consequence for the health of those without housing has been catastrophic. There were 132 deaths in the shelter system in 2021. There were 74 deaths in the shelter system in 2020 and 48 in 2019. This tells us that the number of deaths in the shelter system has almost tripled compared to before the pandemic. COVID and the city's response to it has had a profound effect on the health and well-being of people without housing. Those who died in the shelter system in 2021 had an average life expectancy of only 47 years. About half of those deaths are from a poison drug supply. As an outreach worker, I can't get someone a shelter space. Sometimes we call, we can't even get a hold of a human person on the phone. The shelters are full. People can't get inside out of this frigid weather. The warming centers only open when it's minus 15 degrees, and there are only 4 of them in the entire city of Toronto. It is devastating to only be able to offer someone a sleeping bag when they're asking for a warm bed. I can't even imagine what it's like to prepare to survive a night outside in these temperatures. People aren't even able to access indoor space in a 24-hour Tim Hortons or McDonald's at the moment. We have heard that there are 50 shelters are reported with COVID outbreaks. Over 400 people currently have COVID in the shelter system. The shelter flow data and also stories I hear of what people are experiencing make it clear that evictions, the number of people who are houseless, keeps increasing. 300 or more a month are being displaced into houselessness. At the same time, the city is only moving 40% of the amount of people they were moving into housing compared to before the pandemic in 2019. The shelter system has collapsed. Naming these institutions shelters or respites at this point is an inaccurate term. It is clear to me that the city government needs to act. They need to do much more to address this unprecedented situation. People deserve to be able to follow the same public health guidelines that those of us with housing can. Much more needs to be done to address this health catastrophe that is killing people at an alarming rate. It is imperative that the Board of Health speak up so that the necessary action is taken to ensure the health and well-being of people without housing is valued and prioritized. Please ask for federal relief. We echo Leilani Farha, the former United Nations Special Rapporteur on Adequate Housing, who writes in a public letter, "We urge you to convene an intergovernmental meeting immediately with provincial, territorial, city, and Indigenous officials, International and Canadian Red Cross, UNHCR, Doctors Without Borders, and the University Health Network, and others. Please ask that the city government open more COVID recovery rooms. It isn't right that people are being left to recover from COVID in situ in congregate shelters. Please ask the city to create more shelter hotel rooms available for people. In 2020, the city opened over 2,000 rooms in 4 months. We know the government can do more than they are doing currently. It isn't okay that people need to be in congregate settings during COVID. Please ensure that shelters expand overdose prevention, education, training, and response. Training must include CPR, using bag valve, masks, and other shelter holds. And also, shelter hotels need to implement the Toronto Shelter Hotel Overdose Preparedness Assessment Project. Please ask the city government to stop evicting people from encampments. It is well established that evicting people from encampments is bad public health policy at any time. This is especially true during a pandemic. Please speak up to ensure the health and well-being of the thousands of people in Toronto without housing.
Thank you very much, Greg. Let me open it up to see if there are any questions for you. Seeing none, thank you, Greg. And we have one final speaker before we move this into committee, and that is who was on the list earlier and has now joined, Dr. Roshan Killian. Do we have Dr. Roshan on the line?
They're on the line. I'm now unmuting their line.
Thank you, Nahom. And Roshan, thank you for joining us. You'll have 5 minutes and you can begin when you're ready.
Thank you, Chair. I will start my own clock. My name is Dr. Rujna Killian with specialist qualification in family medicine and emergency medicine and 16 years of full-time clinical experience. The field of medicine is a complex interplay between theoretical and clinical medicine. Theoretical medicine includes research as well as public health. Clinical medicine, my specialty, is where the innovations and advancements of research can be experienced and also where the impacts of public health policies can be observed. But it is clinical medicine that reminds the academia and the appointed health officials of their purpose, the improvement of individual health. And when the health of individual patients are being compromised, it is my ethical and moral duty as a clinician to raise my voice in protest. I quote from a document that I expect the Board of Health to be familiar with, the Tri-Council Policy Statement. Research is a step into the unknown. Because it seeks to understand something yet not revealed, research often entails risks to participants and others. These risks can be trivial or profound, physical or psychological, individual or social. History offers unfortunate examples where research participants have been needlessly and at times profoundly harmed by research, sometimes even dying as a result. And we've seen that today. Ethical principles and guidelines play an important role in advancing the pursuit of knowledge while protecting and respecting research participants in order to try to prevent such occurrence. See reference 1. Vaccines have been promoted and widely utilized under the false claim that they have been shown to improve health. However, this claim is only a philosophical argument and not science-based. In a true scientific fashion, to show a health benefit, one would need to show fewer overall deaths during an extended period in the vaccinated group compared to a control group. Less stringent indicators of health benefit would include fewer severe events of all kinds, fewer days hospitalized for any reason, lower healthcare expenses of all types, fewer missed days from work for any health reason. No pivotal clinical trial for a vaccine preventing an infectious disease has ever demonstrated an improvement in health using these scientific measurements of health as a primary endpoint. See reference 2. I attach a link to over 1,000 studies published in peer-reviewed medical journals documenting the risks of the COVID vaccine. Reference 3. With the debates raging over the effectiveness, legality, and ethics of these vaccine mandates, a way to continually monitor the effect between vaccine deployment and worldwide COVID-19 associated deaths and case rates seems an important contribution to this ongoing discussion. The statistically significant and overwhelmingly positive causal impact after vaccine deployment on the dependent variables total deaths and total cases per million should be highly worrisome for policymakers. They indicate a marked increase in both COVID-19 related cases and deaths due directly to vaccine deployment that was originally sold to the public as the key to gain back our freedoms. The effect of vaccines on total cases per million and its low positive association with total vaccinations per 100 signifies a limited impact of vaccines on lowering COVID-19 associated cases. These results should encourage local policymakers to make policy decisions based on data, not narrative, and based on local conditions, not global or national mandates. These results should also encourage policymakers to begin looking for other avenues out of the pandemic aside from mass vaccination campaigns. Reference 4. Why is ethics of vital importance to a specialist in clinical medicine? Because science is not a god. Science relies on hypotheses, experiment, and validation or falsification of the hypotheses to progress. But it is science's own methodology that also highlights its limitations. Science cannot answer of itself, using its own empirical methodology whether a particular medical practice is morally good. It must rely on philosophy to do so. Moral philosophy extracts truth from reality based on reason and lived experience, hence clinical medicine. There is no neutral void from which a physician can escape his ethical duties, and as a physician, you must serve the patient exclusively, not some abstracted idea of society. Reference 5. I suggest that we start giving clinical medicine and its clinicians an opportunity to guide us out of this pandemic. Academia and public health officials, in fact, might remember the aim of it all, the improvement of individual health. I want to add, hearing what I've heard on this meeting today, even if we just close down the vaccine centers, the assessment centers, and all of the pop-up hospitals, and switch that over to housing for the homeless, that might solve an actual crisis, what I've heard here today. Thank you.
Thank you very much. Let me open it up to see if there are any questions for you from members of the board. Okay, seeing none. Thank you to all members of the public who deputed and spent the time to join us here today on this item. I'm glad that we were able to make time to hear from everybody. We're now going to move this into committee for questions of our staff, both from Toronto Public Health and team, as well as the city. Can I just, by a show of hands, for those on camera, who has questions? I have Councillor Fillion, Councillor Perks, Councillor Ainsley, Councillor Layton.
Councillor Wong Tam, who can't turn the video on for some reason.
All right, so I
Thank
have
you.
Councillor Wong Tam, and I'm going to take a guess and assume Director Mulligan also has questions. Director Mulligan, you can just correct me if I'm wrong. But I have Councillor Wong Tam and Director Mulligan by phone. So why don't we begin? Councillor Fillion, you're first.
Thank you, and I've got several. I'll try to go quickly. I'm not clear, Dr. Davila, on the province's criteria for who's considered at risk for testing. Now, I know obviously the long-term care homes and certain settings, but if you're somebody who's living at home, whether you're 88 years old or you've had cancer or whatever, who qualifies to be tested?
So through the chair, Councillor, you're right. In the first instance, the province is focusing testing resources in highest risk settings. So that includes places like long-term cares and hospitals and other congregate living settings, meaning that they have shared space, particularly with older individuals, given that that's where the risk is the highest. Then if you have people who are clearly unwell enough that they are presenting for medical care to hospitals and other healthcare sort of settings, then those people would obviously be tested as well in order to best determine clinical pathways forward. So those are the circumstances in which testing is really directed at this point in time. But the province, of course, reserves the right to change that as the resource demands change.
But if you're at home and immunocompromised and 88 years old, you unless you're serious enough to go to the hospital, you can't get tested. I think
or
that's a
again,
yes.
there may be circumstances where they're getting ambulatory care or in community care, again, depending on what the clinician sees on presentation. But generally, given Omicron is so present, the general thought is that if you have symptoms consistent with Omicron, you can effectively manage that and consider it to be Omicron, as I've heard the Chief Medical Officer of Health say.
So the second question related to that would be, I understand that the Pfizer medication may be approved today, and in order to for that to work, you have to start taking it within 5 days, as you know. So, which means you have to have symptoms, get a test, get a doctor's prescription, and get it filled all in 5 days. And with the current lack of testing, that doesn't seem possible, again, unless someone is sick enough that they go into emergency, or they just go into emergency anyway.
So through the chair, Councillor, we have just also heard or hearing the same things, that this approval may be coming through shortly. We have yet to hear specifically, or at least I have not had the opportunity over the course of today to hear what is exactly the plan of the province in respect of access to this new medication, which hopefully will be part of our toolkit soon. Once we have that information, we'll be able to better explain to you and other members of the board around what this looks like. How to access this medication.
Okay, thank you. You'd mentioned before that people who are vaccinated are twice as likely or 4 times more likely to avoid serious illness. Is that in straight numbers, or is that taking into I'm not sure whether or not that includes the relative percentages of who's vaccinated or unvaccinated. So are you know, if there's 5 times as many people or 9 times as many people who are vaccinated, is it 9 times 4 or is it just 4?
So through the chair, Councillor, the data that I gave you, which I promise, share with the board as per Councillor Ainsley's request earlier in the meeting, is based on data that we received from the province. It is not for Toronto, it is for the entire province, and it looked specifically at outcomes, vaccinated versus unvaccinated individuals for cases that were identified between December the 24th and January the 6th. And it just compares the rates of hospitalization and ICU admissions for those who are unvaccinated versus those who had received 2 doses or 3 doses of vaccine. And it was clearly in favor with less hospitalizations and much lower rates of ICU admissions for sure for those who'd received vaccine versus those who were entirely unvaccinated.
Last question, if I can squeeze it in, is whether we know yet whether people who are fully vaccinated can transmit Omicron at roughly the same rate as unvaccinated, because people like myself kind of have tended to stay totally clear of anyone who's unvaccinated because they're more likely to get it, therefore more likely to spread it. But I don't know whether Omicron has changed that, because everybody gets it, even those who are double or triple vaxxed.
So through the chair, Councillor, very briefly, our experience with Omicron is fairly limited. As you may recall, Omicron only was introduced within our setting here in Toronto, first case detected in early December. So perhaps what I might do, with your permission, both yours and the chair's, I can ask our team to take a look at that and perhaps come back with what data we have specifically on that. We do know clearly that Omicron is far more transmissible, even for those who've received vaccine. The question is how much more they can transmit relative to those without vaccine. I'll have to go back and see if I can find you specific numbers. I don't have them with me at this point.
Great, thank you.
Thank you, Councillor. Next I have Councillor Perks.
Thank you, Chair. I understand there are staff from shelter, housing, and support here. I was wondering if they could, we've heard both in deputations today and also in public accounts, very alarming information about the state of our shelter system. I wonder if you could give us a quick rundown of what's happening right now.
Thanks, and through the chair, Councillor Perks, for that question. So, you know, certainly the shelter system, these are very challenging times, and you know, we have and continue to make you know, a number of changes and deployment of a variety of different supports to assist people experiencing homelessness in the city. So, you know, as you'll know, we moved more than 3,000 people out of the base shelter system into hotel programs at the start of the pandemic, which brought down the occupancy within our base shelter system. But with respect to the latest Omicron variant and its impact on the shelter system. We continue to work very closely with the Intercity Health Associates that have been referenced. They're our lead health partner. And with the Intercity Health Associates and Toronto Public Health have worked with our shelters to support a variety of in situ isolation supports as people have become infected and impacted by COVID-19 and the Omicron variant. We continue to operate the Isolation and Recovery Hotel, and it does have currently a maximum of 60 rooms available, and we are prioritizing those rooms to individuals who have, health conditions that make them more vulnerable for COVID-19, and we will be working over the next few days to increase the number of isolation and recovery spaces available at that program. Just within the last 10 days, we've made N95 respirators available for shelter staff, and just late last week have started the deployment of N95 respirators for shelter clients. We've pushed out a $4 pandemic pay wage increase for some of our nonprofit shelter providers to support them and the hard work that they continue to do every day in the workplace. And as you know, also we've continued to open new shelter capacity. So at the start of the cold weather season, we were sheltering just about 7,000 people. Last night, we sheltered 7,544 people. The two latest programs to come online have been two community centers, one at the Mazara Cowan Community Center within your ward and another program up at Warden Hilltop in Scarborough. So we continue to be very focused on an hourly basis with respect to the need and the demand for shelter space, while continuing to support our operations. At this point, we've deployed about 100 staff into frontline shelter positions to address some of the vacancies that we've experienced. And just finally, Councillor, I'd say that the ongoing impact of the opioid crisis continues to be the most devastating health impact that we're seeing across the shelter system. As one of the deputants noted, we've seen far too many people die, needless deaths due to a toxic drug supply, and we continue to hope that a provincial and federal guidance with respect to this opioid crisis will be forthcoming.
Thank you.
Thank you, Councillor. Next, I have Councillor Ainsley.
Thank you, Chair Cressy. To Dr. Davila, I wanted to ask, one of the deputants made a point about, I think, I forget the percentage they used, but they said that the Omicron variant they compared it to the common cold. They said it wasn't much worse than the common cold. I was wondering if you could comment on that.
Well, through the chair, Councillor Ainsley, first I'll thank you for the question. I would say this: when we look at that which has been happening over the last several weeks, we have seen this massive increase in hospitalization rates and in ICU usage as well. And this is not, while yes, there are viral respiratory illnesses that do lead some people to experience significant enough illness that requires hospitalization and ICU admission, most notably influenza. I think that in the common understanding from most people, the common cold does not give rise to this extent of hospitalization or ICU admission, even when it is so broadly distributed. What we are seeing here for sure is less virulence compared to previous variants of COVID-19 or SARS-CoV-2, but clearly a very transmissible variant that is impacting a large number of people. And even if only a small proportion of those people requires hospitalization or that higher level of care, it is a large number of people just because of its transmissibility. I think the other point that's worth mentioning, and I meant to mention as part of my presentation, is that the emergence of the Omicron variant actually has a lot to do with the fact that we do have a big task in front of us, and I know this board has spoken to this before, in respect of global vaccine equity. our ability to prevent the next serious variant from emerging on the scene and wreaking havoc here or anywhere else in the world really does rest heavily on the better use, deployment, and more equitable distribution of vaccine, yes, in our community, but even more so throughout the rest of the world. There are significant swaths of the global population that do not have access to vaccine, remain highly susceptible to COVID-19, and create that opportunity for ongoing transmission and therefore the development of new and more challenging, potentially, variants.
And I think, Dr. Davila, the one thing that stuck out with me, if you compare Omicron to the common cold, with seniors, it's not very often that somebody will say, well, you died from the common cold, which seniors seem to be going into the hospital, either they're vaccinated or unvaccinated, and they're dying from it.
Yes, through the chair, Councillor, I think you're quite right. And that's what I was trying to get at through my statements, that this is clearly having very significant impact on people's health and on the healthcare system. You heard a number of deputations today that basically echo this point. And again, it does tie absolutely to our efforts as an international community towards ensuring vaccine is more broadly available to the rest of the world, and that we are actually deploying all the resources in communities the world over in order to protect the entire world. This is truly a global effort, and we have to pay more attention to that.
Yeah, thank you. And Dr. DeVille, I wanted the next concern that I had, and I'm also speaking as a parent whose son went back to high school, or should have gone back to high school today, in grade 10. And I was reading a column over the paper, and it was written by a parent, and her conclusion was that there was an absence of criteria and standards in educational settings for both students and educators. And she compared it to the food service industry, that it's regulated by all three levels of government, including the Ministry of Health. And she doesn't see the same standards in our school settings. And I'm trying to understand how we at a municipal level could get that expressed to the provincial powers that be, that they need stronger criteria and standards for looking after our students during this epidemic.
So through the chair, Councillor, I think we can all agree. I think we heard some good agreement through the deputations even this morning around the value of in-person learning and how important in-person education is to the overall health of our children and youth. To my mind, just to be brief, I do think that the recommendation that I put forth in respect of what can be done to enhance safety within the school and to ensure that we're doing everything we can as a community, whether we're talking about what can be done at the local level, which certainly we are doing everything we can, but specifically we have some recommendations directed towards the provincial government around ensuring implementation and deployment of the best available science to enhance safety within the school learning environment. I do hope that that's certainly what I was trying to get at in respect of that recommendation, and I hope it covers off the points you were thinking of in your question.
Okay, thank you. Thank you, Dr. DeVille. I really appreciate your answers, your time, and all of your hard work and dedication. Chair Cressy, those are my questions.
Thank you, Councillor. Next, I have Councillor Layton, who will be followed by Director Mulligan. Councillor Layton.
Sure. Thank you very much, Mr. Chair. I was just hoping for us to return to the shelters issue just for a moment, but I certainly would want the medical officer of health's input in the ideal set of circumstances when dealing with shelters that are at least our congregate setting shelters. What would be the ideal situation for managing an outbreak?
So through the chair, first and foremost, Councillor, I think if we're actually talking about the ideal set of circumstances, we would be talking about sustainable, affordable, supportive housing. right? I mean, I think that, you know, as much as I appreciate that which my colleagues at SSHA do, I think we can all agree from a health perspective and from, you know, an overall human rights perspective that really we're looking at housing. That being said, you know, we do have protocols and guidance that's provided from a public health perspective around how best to manage risk within the context of a global pandemic, how best to affect isolation that is safe, and there are gradations of risk. Obviously, the more we are able to put people into settings where they can truly isolate from others when they are infectious, the better off you are. This is exactly what we anticipate within the context of people who are housed and appropriately and sustainably housed. The same thing would apply for anyone in any setting, regardless of the nature of the shelter. So I may turn to my colleagues, but certainly we are working with them to provide guidance as best as possible under the given circumstances that we're operating in.
So I guess my question then to you, Mr. Tanner, would be like, we know the onset of Omicron came on very quickly to a system that was already very strained in probably, at least certainly the first time, like despite all what we've been doing, adding hotel shelters, we seem to still be in a relying on our congregate settings just as much as we ever were before. What barriers are there to achieving that ideal situation that our medical officer of health outlined around eliminating or at least having some kind of isolation effort beyond what we currently have? What are the barriers that you face, particularly for this Omicron wave, and what can we do in the immediate term to try to help to get us closer to where Dr. Davila has suggested we should be?
Thanks, and through the chair for your question, Councillor. So I'll say that, you know, we are working immediately on opening additional isolation and recovery space at our isolation hotel, which will provide additional opportunities to move individuals who are COVID-19 positive and likely symptomatic to a setting where they can be supported by some enhanced health services to support their recovery. In terms of additional non-congregate space, if you will, you know, I'd say again that we've moved a large number of people into hotel settings. We have a budget of about 288 million for 2022 to continue those programs. The only thing I would add to Dr. Davila's comments, and it does circle back to the opioid crisis, is that we've seen a dramatic spike in the number of people that have overdosed in our shelter hotels. Individuals who unfortunately have been, you know, using alone and maybe not supported by a robust health or harm reduction system in every one of our sites, and that has led to so many tragic deaths that I wish we had additional health and harm reduction supports to offset those issues, but I will tell you that those deaths within hotel settings continue to be so tragic, preventable, and problematic.
So I would have asked, my last question is, why don't you have those resources and what do we need to get them to you? But instead I'm going to ask this. Are we still looking for hotels, and why can't we get more hotels?
So with our colleagues and through the chair, to answer your question, Councillor, through our colleagues at Corporate Real Estate, we're always on the lookout for additional hotel opportunities, and you know, happy to report back to you with respect to what those options currently look like, if that's your pleasure.
Thank you.
Thank you, Councillor. Next I have, and I know by phone, Director Mulligan. I'm wondering, Nahom, if we're able to unmute Director Mulligan if she's not connected, or whether we've lost her and I need to reach out to get her back.
To the House, it appears that Director Mulligan was dropped from the meeting, but I see that she's connected again. Director Mulligan, I'm unmuting your line. Director Mulligan, your line is currently unmuted.
I'll reach out to Kate separately here, and we'll come back to her. Councillor Wong Tam, I see we've got you back on video. So when you're ready, and I'll reach out to Kate separately.
Thank you, Chair, and thanks for starting the clock again. I'm in a room in my apartment that has this poorest Wi-Fi, so I apologize for my video bouncing all over the place. My first set of questions, and I recognize there were like 3 staff presentations, so I'm going to try to break that up in a way that is organized. My first set of questions would be for Dr. Davila. In your presentation, you showed a map about where vaccine take-up was stronger and where it was weaker, and in terms of lacking, so a larger population that is unvaccinated. And I think that we are on the topic of a recommendation that you're putting forward about bringing the kids back to the classrooms. So I guess my question is regarding how do we square those two? Because we're trying to create a safe condition in the schools, but at the same time, there are going to be neighborhoods where we still have a lag in vaccination rates. But I think what I'm hearing is that you're saying send the kids to school anyways while you continue to work on that. Is that correct?
So through the chair, Councillor, as it turns out, the decision around whether the children go back to school is one that's under provincial purview, and it's one that they've taken. So at this point in time, what we are doing is everything we can at the local level in order to ensure that the learning environment, the in-person learning environment, is as safe as it can be, and that all the enhancements are in place. In speaking to our team that actually has supported schools, and managed to provide guidance to the schools, they are in active conversation all the time with schools and school boards in respect of infection prevention and control measures and public health measures. They do note that in general, we are finding that with layers of security and protection, if I can use those terms, in school, it does absolutely make a difference. That's their impression based on their own on-the-ground experience in managing COVID outbreaks at school, including to all the way up until the break for the winter holidays. And yes, vaccination is one of the key layers of protection, which we're pushing as much as we can.
Okay, thank you. Chair, I don't know how my time got to 3.5 minutes, but I'll try. That was one question.
Councillor, you're only at 2 minutes and 15. I've been keeping it separate.
Okay, thank you so much. Thank you. And Dr. Davila, my next question is regarding the parents that spoke today, Mr. Hartman as well as Ms. Nolan. I guess because I didn't really know how to, it was especially Mr. Hartman's case, I think is something that we can all just quite be very sympathetic to. And they didn't have a chance to speak to you, but what advice would you provide those 2 parents who probably are coming to us for some type of response? And I know that, you're probably the best person to provide some response to them.
So through the chair, Councillor, I don't know that I am the best person to provide advice without having a real relationship or a full understanding of the circumstances. Certainly my heart goes out to parents all over the province. Obviously, we're responsible for what happens in Toronto, and we provide public health service, to Torontonians. My understanding is that based on the deputations we heard, we were talking to 2 people from outside of jurisdiction. So I hesitate to step on other people's areas of responsibility, but I would encourage them to have conversation with a trusted healthcare provider who's knowledgeable around the circumstances of the case, because I'm sure they're seeking answers. And I think as parents, for those of us who are fortunate enough to be parents, you can appreciate why you would want to have, you know, answers and to really look into the circumstances in those very, very unfortunate and tragic cases.
Thank you. I have one question for Gord Tanner and then one question for Chief Pegg. The first question for Gord, during, and this, for the entire Board of Health, you may not be privy to this, but Gord was at the Budget Committee and he provided some responses to questions about SSHA's resources. So Gord, I think you know where I'm going to this. You were asked a question about whether or not you had the resources to sort of, you know, take care of the shelter crisis, sort of manage through the winter readiness plan. And your response at the budget process was, yes, you did have those resources. And you can correct me if I'm wrong if you didn't say that. But I guess I'm trying to understand that as you scale back up the isolation infirmary style beds, do you still believe you have the resources you need based on the 2022 allocations, as well as how many new isolation infirmary style beds can we anticipate based on what you've just said to Councillor Layton?
Through the chair, thanks for the question, Councillor. So, you know, we do have authority through council to respond to demand for shelter and increase additional space. And, you know, through our work with the strategic leadership table at the city, have been able to flex that additional space when it's been needed over the course of the past while, including this past weekend, which requires more staffing and dollars to be put forward to run those services. With respect to the isolation and recovery site, we will be attempting to increase its capacity by up to another 60 rooms at that location. The ramp up could be gradual, as of course we'll need to work with our healthcare and harm reduction partners to scale up that capacity as space becomes available at that program.
So then we'll be sitting at 120 as opposed to 60, is that correct? You're doubling it.
That's correct.
Okay, thank you very much. My last question is to Chief Pegg. Thank you very much, Chief. You've been very patient on the call today. I wanted to just ask you, with paramedics who may be sick or perhaps we have some shortages, unlike, you know, I know that City of Toronto has divisional staff are being shifted right, left, and center as we sort of cover the essential services. The type of paramedic training is not one that can easily be recovered. So you can't shift someone over from city planning to work, drive an ambulance and send them out to paramedic calls. So can I just ask, how are you dealing with staff shortages within the paramedic service? And if you are asking paramedics to do overtime, at some point in time, the supply of labor is finite. So how are you managing that as well?
Yeah, Councillor, just over 7 minutes.
Okay, that's my last.
These have all been important. So, Chief, I'll turn it over to you.
Thank you, Councillor. Through you, Mr. Chair. You're exactly correct, Councillor. The work that is performed by paramedics and the other members of our emergency services is both specialized and unique and requires specific training, and therefore, generally speaking, not able to be backfilled by way of redeployment across the city. So, therefore, we are almost entirely dependent upon overtime and things like shift extensions. So staff working longer shifts than they normally would, working additional shifts to what their normal schedule would be in order to maintain those frontline services. And I will say at this point, that is holding. They're doing an exceptional job. Actually, over the last number of days, our mitigated unplanned absence rate, so that's the actual situation on the ground, if you will, continues to get better and better and better. So it is happening very much at the hands of our very dedicated staff who are going above and beyond.
Thank you very much. We're now going to try to return to Director Mulligan, who I understand we've reconnected. And again, my apologies for all the technical glitches. But Director, do we have you back?
I'm here. Can you hear me?
We can hear you loud and clear. Thank you. Over to you.
Thank you. Thank you very much. Dr. Davila, we've often heard that schools should be the last to close and the first to open. And that seems to be the priority of Toronto Public Health that we're hearing here today. We've also heard that COVID's really a story of work and workplaces. So my question is, what new public health measures in non-school environments like workplaces have been implemented during this Omicron wave so that we can reduce overall contacts in communities and thereby prioritize the contacts that do happen in schools. So for example, are we requiring HEPA filters in businesses, especially in high-risk occupations or high-risk neighborhoods? Are we requiring upgraded masks like the N95 and KN95 respirators? What is within Toronto Public Health and the City of Toronto's power to do here? And what should we be asking the province or other levels of government to do? Thank you.
So thank you, Director Mulligan. Through the chair, a couple of things. A lot of this does really fall within provincial purview, and what we are trying to do is to maximize what we can do here at the local level. Certainly what we have done is we have supported and provided advice, for example, on things like vaccination policies for workplaces, including some basic templates around how best to, or what sorts of considerations need to be put into place to support optimal vaccination within the workplace. Similarly, we have quite an extensive function in what we call a liaison role to support workplaces and other agencies within the community on best practice, if you will, in infection prevention and control. So these are just a few examples of that which we can do at the local level. Requirements, particularly around workplaces, start to get into the realm of the Ministry of Labor, Training and Skills Development, I believe they're called now. So these more rightfully fall within the provincial purview, but where we can, we are certainly providing supports, guidance, templates and tools to ensure that local agencies and workplaces have some resources as they seek to create safer environments and mitigate the impact of COVID on their workplaces.
Thanks, Dr. Davila. Do you think that enough has been done in that area in order to support reopening schools?
Sorry, do I think that has been done enough in the workplace?
Yeah, that's right. Have we done enough to implement public health measures in non-school environments like workplaces so that we're reducing overall transmission and making it that much safer for schools?
So through the chair, I think that there is an opportunity certainly to provide more supports to places. I don't pretend to have a clear line of sight on that which the Ministry of Labor is actively considering and what they might be doing in the not too distant future. But certainly, we do support from a public health perspective. The more we are able to limit transmission within the community writ large, the safer will be all the essential services that need to continue to operate, whether we're talking about hospitals and healthcare, long-term care, or our schools. All essential services, groceries, let's not forget them, and the many other services that we need to continue daily life. All of these are made safer by reducing transmission as best as possible and using science to advance the reduction of transmission.
Thank you. Does Toronto Public Health or the City of Toronto have the capacity to provide better filtration like HEPA filters or better masks for the very high risk essential workplace environments? And secondly, do we have that capacity to do so for students in schools and children and staff in childcare centers?
So very briefly through the chair, Director Mulligan, that is outside of our capacity and our scope. When it comes to workplaces, that this would more rightfully fall to the Ministry of Labor, Training and Skills Development. And when it comes to schools, that's within the purview of the Ministry of Education. We do provide, as I've mentioned, a great deal of guidance and support on infection prevention and control and public health measures at school, everything from advice in respect of screening to hand washing to infection prevention and control practice and cohorting. And of course, I would be remiss if I didn't mention our efforts along with our Team Toronto vaccination partners on vaccination for school communities, students, their families, education workers, etc., and childcare, of course.
Thank you. I appreciate those clarifications. There's certainly a lot of confusion among students and families and caregivers about the different advice and the changes that are happening right now. For example, is the Toronto Public Health of the view that the 3-ply masks being offered to students in schools are adequate for this, for reducing transmission in this Omicron wave?
So through the chair, our advice in respect of masking mimics that which you see from the Public Health Agency of Canada and from Public Health Ontario. And basically it's this, that, you know, people are recommended and advised to get the best mask that they can, the highest quality mask that is available. Because really what we're looking at when we're talking about a highly transmissible variant like Omicron is fit and filtration. These are characteristics that help in respect of, you know, the protective benefit of the mask. You want that mask to fit extremely well around the nose and around the mouth and chin to limit the amount of air that is actually coming in and being breathed in and out that goes around the mask. You want as much as possible for filtration to happen through the substance of the mask. I would be very happy to provide members of the board with this information. We do have this available on our website, and I would refer people as well to the Ontario COVID-19 Science Advisory Table in respect of masks and the guidance as well from Public Health Ontario and from the Public Health Agency of Canada.
Thank you. So just
Oh, sorry, you're just over 7 minutes, Director. Do you have one final quick question?
Yes. I just wanted to clarify that prior response. Just so, do the provincially supplied 3-ply masks meet this standard of requiring higher supports and better filtration, better fit?
So certainly they are better than some of the cloth masks that will be out there. And again, to my mind, the better the more high quality the mask, the better it is. I think the other point that's really important to note here is that yes, you absolutely want a high quality mask that has good fit and filtration, but the mask also has to be worn. And that's one of the challenges, right? When you get into really good fit and really good filtering masks, they do, unfortunately, get more uncomfortable. They are more difficult to wear on a consistent basis. So that is one of the challenges here. So you're looking for the highest quality mask that actually is consistently worn in a proper fashion by the individuals who are, you know, donning those masks.
Thank you, Director. Thank you very much. I have Director Sue Wong.
Thank you very much, Mr. Chair. My question through you to staff. I want to follow up with a couple of the recommendations and statements made by one of the Deputy, Kathy Crow. So she stated that the city have reduced the capacity from 160 capacity bed to 60. And I want to hear the staff rationale or explanation why there was that significant reduction. Is it related to staffing? That's the first question. My second question is that I heard Mr. Tanner talked about that there will be increase in the isolation hotel or the recovery hotels. Are they going to be located all over across the city? Because there's a tendency that these beds, these isolation beds or recovery hotel are not in Scarborough. So the northwest part of the city as well. So through you, Mr. Chair, can the staff answer these questions for me, please? Thank you.
Thanks for the question through the chair to the director. So we have one isolation and recovery hotel, and so the city sort of purchased all of the rooms in a hotel. It's got 160 rooms total, and that has been the hotel we've been using throughout the pandemic to move people to who are COVID positive, or people at times who may be symptomatic and awaiting test results. over the course of the summer, that hotel was almost empty. And so, and I'd have to reflect back on the data, but, throughout the summer and into the early fall and, towards the start of winter, we reprofiled some of the rooms in that hotel to become available to people seeking shelter. As we continued to see demand for shelter space, we moved some individuals into those rooms and decreased the amount of recovery and isolation space that was available down to the 60 rooms that you reference. There is just one hotel in the city, and we have quite a complex and robust transportation system that at any time, any shelter in the city, would have somebody who is not passing a screening for symptoms. They would be assisted with transportation first to an assessment center to receive a PCR test, and then pending the results of that, taken to the recovery isolation hotel. And if it was COVID positive, they would remain there until they cleared, and then they would be assisted with transportation back to the shelter that they have been staying at.
Thank you very much, Mr. Chair. That's our question I have.
Thank you. Let me open it up to see, are there questions from any members of the board who haven't had a chance yet?
Mr. Cressy, this is
Trustee Lepretti, you have questions?
I have two questions.
Please go ahead. And I think your audio is just a little quiet, so you may want to speak close into the mic, but you're up, Trustee.
Okay. Can you hear me? Okay, so this is, I know that this isn't under the purview of the city or the scope, but there seems to be a lot of confusion with parents and stakeholders. And I'm hoping that you may be able to clarify, one, why has PCR testing stopped in schools when we would test entire school communities to see the transmission within the school? And two, there's a very big misunderstanding about why Toronto Public Health has stopped reporting publicly COVID positive cases in schools. So I'm just hoping that you can help parents understand why this is no longer happening.
Sure. So through the chair, Director Lepretti, I will try to make this as simple as possible because I realize there's a lot of information and arguably some misinformation out there and a lot of changing circumstances, which adds to confusion. So very, very briefly, the decision was taken at a provincial level as testing is under the province's purview. This being said, with a very transmissible variant like Omicron, effectively, what has been found here and in other parts of the world as well is that there are simply not enough testing resources to keep up in a timely fashion and to manage the amount of transmission that we're seeing. This is a very, very transmissible variant. I mentioned in the remarks that compared to the last variant we were dealing with, which also created a lot of cases earlier last year, actually now, this one is infects 4 times more individuals than a Delta case did in the past. So it is just a significant number of cases and a significant amount of transmission that happens, thereby outstripping testing resources. Hence, testing resources were focused by the provincial government on those settings where the risk is the highest for negative and serious outcomes associated with a COVID-19 infection. And as you've heard me describe in an answer to another question here today, that includes places like long-term care homes, hospitals, these high-risk congregate settings where you have older and or sick individuals who are more likely to have negative outcomes associated with a COVID-19 infection. So without having the testing, it is effectively impossible for us as Toronto Public Health to comment on or to advise on cases because the cases were identified through the testing regime. And because the testing has now been more redirected towards these higher risk settings, we don't have the same capacity or ability to identify a case and therefore notify people within the school system.
That was brilliant. Thank you so much for explaining it that way. Thank you. I don't have any further questions.
Thank you, Trustee. Are there any members of the board who've yet to have an opportunity who have questions? Okay, seeing none, we'll move this into committee. Can I see, for those by phone, to unmute and indicate so, or by way of a show of hands, speakers on this item? Can do another call. Are there anybody who wish to speak on the item? Okay, and anybody by phone, speakers on this item? Let me do a call, and if not, if I'm the sole speaker, I will put myself down. Oh, Councillor Wong-Tam. When you're ready, Councillor.
Oh, sorry, Chair. Would it be okay if I spoke after you move the motion?
Yes, that's fine with me. Let me just see if there are others who wish to speak. Perks after, okay. Well, listen, let me then kick it off. And so I will begin, first of all, by moving the staff recommendations in front of us, as well as placing a comprehensive set of motions. And let me begin by saying, with deep and huge thanks to all members of the board. So there's been a tremendous amount of work on this over the last number of days. So to our recording secretary, if we can put the motion up, and I will summarize briefly and then speak to it. So first, moving the staff recommendations from Dr. Davila to accelerate the hyperlocal approach to third doses, including at a building specific and door-by-door basis where feasible, to explore incentives to continue to increase vaccination uptake, to request the province to enhance and expand education and outreach to support our 5 to 11-year-old campaign, to support maintaining in-person learning and making schools safer through access to testing, to improve access to PPE, including high-grade masks and ventilation, to reaffirm our request that COVID be included as one of the infectious diseases for which vaccinations are required in the schools, to reaffirm our request to the federal government to immediately, urgency, and with every ounce of effort we have to address global vaccine equity, to address this pandemic once and for all, to call on, to request the medical officer of health to work with our school board partners to explore and increase public reporting of cases and outbreaks, to request our medical officer of health to work with our deputy city manager to explore opportunities to expand the distribution of high-grade masks, especially in hard-hit neighborhoods, and on workplaces to request the province to immediately update COVID prevention measures in workplace settings, including requirements around the direct provision around HEPA filters and N95s, especially in neighborhoods of highest risk. And I would note in particular here, and I know other members of the board will speak to it, for our medical officer of health to work with the city manager and the general manager of Shelter Support and Housing Administration to expand recovery facilities and non-congregate beds, to increase the number of housing allowances, to expand overdose prevention work throughout our shelter system, to call on the feds to expand rent subs and to use their emergency powers to secure housing now, and to call on the province to fund and support our supportive housing program. Colleagues, that was 2.5 minutes just to go over all of this work that all of you collectively we've worked together on, and I thank you for that. Let me, having summarized that, thank our medical officer of health, who between the last meeting and now left and returned from surgery as she continued to lead us personally alongside an incredible team through this response, to the Toronto Public Health team, who literally worked through the holidays at a moment's notice to accelerate our third dose campaign, into the citywide team. You heard from Chief Pegg and Paul Johnson, but there are thousands upon thousands who are part of this citywide effort for continuing under the weight of this moment to provide the continuity of services that are so essential to our residents, to expand and accelerate the distribution of vaccines, and to lead all of this with a clear view that protecting the most vulnerable and supporting the most vulnerable is our highest calling. This Omicron stage that we're dealing with, this variant is highly transmissible, but the vaccines, thank goodness, are proving effective at protecting against severe health outcomes. And so in this moment, I would summarize our work as 3 concurrent objectives: to continue to accelerate the vaccination campaign, to protect our population, to reduce overall transmission so as not to overwhelm our services and system. Everybody cannot get sick at once, and we need to continue to reduce transmission. And third, to continue to deliver essential services, especially for the most vulnerable, amid significant staffing shortages. All 3 are objectives. All 3 are extremely challenging. And after 2 years of this, all 3 place a heavy burden on our residents. But we have the tools. We have the tools and the know-how to confront this moment, and we have the vaccines to protect people. I mean, imagine if Omicron had hit 2 years ago before vaccines. This would have been the plague. But we're not in that state because of vaccines. And our first and second dose efforts are paying off. Nearly 90% of residents have got their first dose. Nearly 87% have got 2. Our third dose efforts have seen 50% of all eligible Torontonians now get their third dose. That's through dramatic acceleration of the campaign. 50% of kids have now received their first dose in just over 7 weeks. And in long-term care, 92% of residents in our 10 city-owned long-term care facilities already have their 4th dose. These are remarkable, remarkable achievements, but the work continues to address disparities that exist throughout our city, to address deep barriers to access, systemic and historic mistrust. All of that work must continue, and our motions speak to that. And I want to note, in the context of our shelter and drop-in system, housing, permanent housing, remains the prescription. But this moment demands immediate protection through PPE, through physical distancing, through access to physical distancing and recovery, through overdose prevention, and through vaccines. We must meet that moment. And when it comes to schools, and I thank the board for their indulgence as I'm trying to address many different pieces here on my time. When it comes to schools, I believe to my core that schools are essential for our kids' health, their development, and their well-being. They are essential. Grocery stores and food banks are essential to food security. Pharmacies and hospitals are essential to our overall population's health. And schools are essential in-person places of learning for our children. But they need to be open and safe. Too often this debate has become, are they safe or are they open? They need to be both. And on the advice of our MOA, our Medical Officer of Health, and with these amendments, I support opening schools and adding measures to improve their safety, locally and provincially, from access to testing, to enhanced PPE, to mandates for vaccines, to accelerating vaccines, and working with the school boards to report on it. You know, there's been a lot of debate on schools, and there should be. There are kids, they need and deserve to be safe, and our task is to ensure that they are open and safe, working with our partners. So I will simply close by saying we will weather this storm, and our work continues. We are in a better place today than we've been at any in the past 2 years, as hard as that is to see, and we will weather this storm. Thank you for the indulgence on time. And with that, I will conclude and turn the floor next to Councillor Wong-Tam.
Thank you very much, Chair, and thank you for moving that motion. I took great pride in working on that with a number of councillors and the board members here. It is of course, a very challenging time for all of us. It's not just winter because the sky is so dark, and I'm sure that we are just all very tired, but I can't imagine that anyone is more tired than our staff at Toronto Public Health. To Eileen and to Councillor Cressy, our thanks to you for all that you do. It is, of course, going to be a very hotly discussed topic, school reopening, school closing. Every time there's a moving of the needle, I think all of us have an opinion. What I want to just perhaps share is just some thoughts about, the schools. I'm a firm believer that kids need an education, as we all do. And I think that we can all also agree that online learning is just it just doesn't work for a large number of students, especially when students, especially the younger kids, when their social identity, their development and growth is so tied to their personal social interactions with one another, with the clubs and with physical activity, with drama and art classes. We have, taken that away over the past 2 years, and it's been very spotty. And schools should have been the last to close and the first to open. I really strongly believe that. And we have heard from the CEO of Sick Kids Hospital, who cited the other challenges of keeping kids out of the classrooms, right? Including the fact that they're seeing higher rates of depression and anxiety, and how do we sort of trade off, what is more risk management in terms of doable. And I think it's just been too long. And I know that this is going to be hard. I know that we are probably never going to get to 100% vaccination, and we have to have a tough conversation about that at some point in time. There are going to be communities where they have had traditionally long relationships and distrust with either government or big pharma or policing and what have you, that will probably not take up the vaccination, no matter how localized our efforts are. They just are not going to do it. And I don't want to be defeatist, but I want to be realistic about where we are. And does that mean that we grind everything to a halt until we're 100% there? And I think we can all recognize that that's just not realistic. Those communities are also communities where they've had a social contract with them broken. Therefore, we cannot demand that they just believe us. We can't, cajole them and compel them to do what we say. We have to dialogue with them, and that's what I've been trying to say, is that I know that this is hard and we have to do it, but it's those one-on-one interactions which we have to continue to advance. And we may have to just come to a conclusion that maybe they're not going to be where we are, and that is how we're going to have to figure out how to live and accommodate one another. I want to just speak about the shelters for a moment. There's been an image circulating on social media that I think each and every single one of us, if you haven't seen it, please do look for it. It's basically an evening bus on the Danforth and Bloor route, where I think it's a bus or a streetcar. Sorry, it's not. It would definitely be a bus. And there are about 5 or 6 individuals, 7 individuals that are all slumped over, sleeping on this TTC vehicle at 2 o'clock in the morning, trying to stay warm. And if that is not a symptomatic image of how broken the shelter system is, and it has been for years, I remember very clearly that we were all rallying, and some of us on council going back to 2017, asking that we deal with the shelter crisis, 2018, 2019, all without a lot of success. And that image becomes the postcard image of the face of Toronto. And that is a responsibility and I think shame that we all carry as civic leaders and decision makers. So to Mr. Tanner today, your response to me was encouraging. I really appreciate you coming and sitting with at the Board of Health. I know you've got a tough job. We all appreciate everything that you do. But I think there has to be even more done. And I know that people are tired. I totally get that. But we still have more to do. So please, I'm going to encourage you to work with the advocates and those who are living with the experiences of homelessness And we need to be able to scale up now more than ever before, because it's not just, of course, homelessness we're battling. We're battling the pandemic. We're battling an opiate crisis, a mental health crisis, everything that has been largely undealt with. This is our challenge. And then finally, I just want to speak to Chief Peg, not directly, but through you, as Mr. Chair, is that I was quite taken back by the code red alert on the lack of paramedic vehicles. And I know that there has been some explanation that it takes a little bit longer to offboard and to transfer the care of the patient from the paramedic to the hospital. But I also want to note that this is on the heels of probably decades of austerity and the downloading of services and the erosion of services in the health hospital sector. So we can try to fix that from the provincial side, but we also need to fix what we can from the municipal side, is the fact that we don't have enough paramedics on the ground today. That 2019 City Council had a staffing plan, a multi-year staffing plan that I don't believe has been fully implemented. And the fact that we are losing paramedics, highly trained paramedics, through attrition faster than we are onboarding. So that is another crisis. I don't want to say crises over crises, but it seems to be another one that we have to be paying attention to. And that's the one we're going to have to address in the 2022 budget. Thank you very much.
Thank you, Councillor. Councillor Perks.
Thank you, Mr. Chair, and thank you so much for the work you've done during the day with several of us to bring that consolidated motion that addresses a number of the dimensions of the pandemic that we're all struggling to try to find the right answer for. I want to address my remarks to two. Councillor Wong-Tam mentioned the shelter system, and of course pointed out correctly that that's the result of a long period of neglect by all orders of government. But I happened to be reading through the city's budget, which came out on Thursday, in the affordable housing portion, and I wanted to share with members this one set of numbers. This is the amount of money being spent in the City of Toronto over the next 10 years on affordable housing by the three orders of government. The City of Toronto is spending $810 million. The federal government is spending $158 million, and the provincial government is spending $3 million. They've also shortchanged us on the money necessary for the staff to support people who are in supportive housing, which is where an awful lot of people who are currently in our shelter system will likely wind up. They refuse to give us permanent and ongoing funding for that, even though providing health supports is the responsibility of the province of Ontario. I am not proud of the record of the City of Toronto. Like Councillor Wong-Tam, I have been part of a group of councillors who have been trying to get a more robust response to homelessness for over half a decade now, including pre-pandemic. But I am appalled, disgusted, reviled, and heartbroken by the response of our provincial government, who has simultaneously walked away from its responsibility on housing, walked away from its responsibility on health, and has created an eviction mill, or turned the landlord-tenant tribunal into an eviction mill. It shocks the mind, and I think we all need to be mindful of that. And I think we need to be clear with Torontonians that the province of Ontario, who has responsibility here, is doing next to nothing. On the matter of schools, we find ourselves in a similar position where we're debating whether it's right to send kids into an unsafe school system or right to keep them home. We should be, all of us, all orders of government, all Torontonians, participating in an effort to make the school system safe. That's what we should have spent the last 2 years doing. We should be looking at some of the Northern European jurisdictions where they have managed to keep their schools open by investing heavily both in the physical infrastructure necessary to make the schools safe and in the practices to make the schools safe, keeping small cohorts separate, which are separate from each other, so that if there's an infection, a small cohort gets dismissed. Having regular testing, having regular air filtration and air cleaning at a high quality standard of quality and care. Having all the protective equipment and training and support necessary within the school system. I feel so sorry for the frontline staff, the City of Toronto, and in the Toronto District School Board and Toronto Public Health, and our shelter system, and in the shelter systems of the various not-for-profit agencies who offer them, who are having to patch together with Scotch tape and string systems to cover for the fact the province of Ontario has failed in every dimension of being prepared for and handling this pandemic. I've had enough. I've had enough. And the fact that the Premier thinks he can just drive around and shovel snow today as some kind of compensation for his deep failure just makes me angrier. Thank you.
Thank you, Councillor. Next, I have Councillor Perks, or sorry, Councillor Layton.
I don't know if there's much more to say to Councillor Perks' comments. Just giving my thanks to staff for their continued efforts. Thanks to our chair and the Board of Health. I would like to just touch on one point that was raised by Councillor Wong Tam and Councillor Perks around Toronto shelters. This problem has been a long time coming, as pointed out by our medical officer of health. The real solution to it is supportive housing, and we can't even get an agreement from the province on how to continue funding it. The budget was announced last week with a $45 million hole for supportive housing that we've rolled out the last 2 years, and we actually hope to do more in the coming years. And we are unable to without the supports of those levels of government. The images that we saw over the weekend are incredibly disturbing, and I know that the folks in our shelter support and housing division are doing all they can. We just need to make sure that the Board of Health, as well as City Council, give them the resources and political will necessary to do everything possible. I think if I had more time during my questions, I would have gotten to the point that Mr. Tanner would have said, we simply there are simply no other hotels out there that will lease to us as a city. And we need to change that. And the only level of government that can change that is the federal government. And they need to come in, if they're serious about a homeless emergency, they need to come in and start doing that now. Because we've reached a point that we've done more in the past 2 years than we've ever done before on this file, because we've had to rise to the occasion. But unfortunately, it's simply not within our municipal power to take that next step and actually start expropriating properties or paying the premium that would be required to acquire some of these sites, if that's even possible, which I'm not sure is. The crisis at its core has as much to do with a medical and mental health crisis and addiction crisis as it does one that has to do with the lack of units. That's why we need those supportive housing dollars so badly. And I hope that all of you will join me in the coming month or 2 months as we advocate to the province to try to ensure that they come through with that money and we don't end up with more people out on our streets next winter. Thank you.
Thank you, Councillor Layton. Are there any other members of the board who wish to speak on this item? Just scrolling through. Okay, seeing none. Is it the will of board? Can we take the amendment and as amended? Can we take the staff recommendations and the amendment as amended? Seeing support for that. So all those in favor, by way of a show of hands on those on the screen. For those on telephone, any opposed? I'm looking on the screen and I'll wait to see any on the phone. That carries unanimously. Thank you. To our recording secretary, do I need to do item as amended, or was that considered item as amended?
Mr. Chair, it's a simple amendment because there were no staff recommendations on the floor.
Oh, the staff recommendations were in the presentation that I moved. So no item as amended.
That's correct.
Understood. Gotcha. Okay, with that then, colleagues, that concludes today's Board of Health meeting. I know it was a long and complex one, as this wave is. So thank you to the members of the board. And can I express, as we conclude, our deepest and collective gratitude and thanks to Dr. Davila, the entire Toronto Public Health team, as well as the entire City of Toronto team, of which we heard from some of our strong representatives here today. Our deepest and ongoing thanks. We need you all now more than ever, and I look forward to seeing you all soon. Thank you very much.